You're listening to Ride Along, EMT School. I'm Mike.
And I'm Max. We're two students navigating EMT school, bringing you along week by week.
And I'm Jonathan, a paramedic bringing real-world perspective.
Join us as we share the lessons, challenges, and stories from EMT school, and hear insights from those already living the EMS life. Welcome to the Ride Along. God, I love that song.
It's a good song.
It's so good.
I still don't, we've heard it, like 41 times now?
Way more than that.
Oh, more than that.
We've heard it more than that. But
way more than that.
It's 41 episodes of that song. I still love it.
Twice an episode, beginning and end.
You know, there's some people that give us hell for that song.
Yeah.
They're just wrong.
certain individuals that are just not correct.
Yeah, they're too hardcore for us, I guess.
Yeah, I guess.
They're like, no, it's not metal enough. I'm like, we do a lot of metal references on this show. Like,
Quite a few.
Yeah. One of which being tonight's episode title.
Oh, that's right. We have an episode tonight.
Yes. Oh,
Hello,
yeah.
welcome back.
Yeah. Welcome to the Ride Along EMT School pod. We've totally started blowing past the introduction, right?
We really have.
We just kind of roll into it. But yeah, we're welcome to the Ride Along EMT School podcast, where you get to learn about all the things we learned about going through EMT school.
Whether you want to or not.
Yes. But we have a special episode for tonight, not because it's any different than some of our other episodes, but because we're dealing with a quote unquote special topic.
We are indeed.
Tonight's episode is titled Tied to the Machines That Make Me Be, which bonus points to anybody who comments and tells us what song that's from without looking it up. I can't keep you honest, but hopefully you'll know if you're an old metalhead like us. And that's a good song.
It is a good song.
I've listened.
It is very appropriate for the subject.
Probably worn out that album.
Yes.
More than almost any other.
I wore out the tape. I'm old.
Yeah. I'm surprised you didn't wear out the reel-to-reel or the...
Yeah, I was a little past that point, but cassette tapes. Oh,
the
yeah.
8-track in your Camaro.
What's a cassette tape, guys?
What's a cassette tape?
All right, millennial.
Yeah. Why is a Bic pen?
I'm just kidding.
Why should you always have a Bic pen with your cassette player? Ooh,
a Bic pen?
A Bic pen specifically.
Oh, I
so
don't.
You can rewind your tapes.
So it fits perfectly in the sprocket for the cassette tape.
Oh, I thought that was what a number 2 pencil was for.
No.
Because a number 2 pencil will work in that. It works as a sprocket or a gear within that little tooth there.
Number 2 pencil will work, but it can get stuck, and the Bic pen
and it's slippery. But is it the little nub on the cap of the Bic pen?
No, the Bic pen has an octagonal shape.
Oh, you're talking about the clear,
Bic pen.
Bic
Come on, you
pens.
you gotta like spell that out for us, because to me a Bic pen is that white matte finish.
No.
Bic pen.
The clear bodied Bic pens, the old school caps that were useless Bic pens.
Hexagonal, like a number 2 pencil.
Exactly.
Yep. All right.
Now we're ADHD tangent over.
Do you guys have a favorite pen for working in EMS, by the way? Because this could be a real thing.
I actually do. The mini Right in the Rain
Ooh.
is a fantastic pen.
I have a new one for you.
You do.
I do.
And it's cheaper because the Right in the Rain ones are freaking expensive.
You can't get more expensive than the Right in the Rain ones.
No.
What about you, Jonathan?
I do. I like the Pilot G2 minis with the fine points.
Oh,
The 0.5.
the G2 is
the 0.5, not the 0.7.
It is a fine pen. As a matter of fact, I remember being on shift the other day and someone handed me a pen to help fill out the clipboard, our transport sheet. And I immediately started writing with it. I'm like, oh, this is a G2. And I looked at the side. I'm like, yeah, you can't.
Right.
Yeah, like they work. They're beautiful. They write beautifully. We did not intend to talk about pens.
We really did
in this episode.
And we went from metal to cassette tapes to pens.
Yeah, I mean, this is what we do, right?
It's what we do.
It's because we probably fall into tonight's category of special needs patients.
100%.
We're all on that spectrum. I know I'm definitely in the ADD spectrum. But,
Yes.
Pens wise, a Uniball power tank
Yes.
by the way.
Okay.
If there's any nerds out there like myself that have an affinity for Right in the Rain pads and like stuff like that, if you have, usually you have to use either the Right in the Rain pen or a Fisher Space pen.
Yeah.
A pressurized tank, right? That's what you need to be able to write in the rain with a pen with a Right in the Rain pad. However, there is a company that makes a cheap pressurized tank pen, and it writes beautifully.
There you go.
The Uniball power tank. I have a whole box upstairs. I'll give you one.
Yeah, he sent us a link for it in class. I was like, yes.
Yeah, I know it's weird, but like sometimes you find those things, you're like, oh, that's it. That's the holy grail that I've been looking for of pens. But yeah, so pens.
Thanks for tuning in. We'll see you next week.
That was our tool. We should do pens as a tool of the
Probably
trade.
should.
But so yeah, we're tonight we're talking about special needs patients.
Yep.
All of those patients out there that give us a little bit of something different to our day.
Yeah.
Right. So I'm sure those of us that have been riding, that have been out there, that have gotten some experience, we understand the difference between, well, actually, I don't even know if you can really make this statement because every patient is unique in some way.
Sure, absolutely. But there are some patients that you have to spend a little bit extra time, a little bit more thought, and a little bit more care with. That's just a reality.
Yeah.
And that just exists, and that's kind of what we're talking about tonight.
Yeah, we have to help overcome some special situations,
Yep.
some unique challenges, and really, it's all in that mission of great patient care.
Yeah.
Right. So that's what we're talking about tonight. And there's a whole bunch of stuff that fit into that category. Everything from the things that we would typically think of as, patients with special needs, like the autism spectrum, or like cognitive disorders.
It could be a child.
Yeah.
I mean, just the simple fact that you have a patient that cannot communicate with you what is going on with them.
Well, yeah, I mean, children with, disabilities is one of them. But anything with like even blindness, deafness,
Sure.
patients that have these disabilities. So that's what we'll be talking about tonight is how we can approach, these different types of situations, everything from disabilities that patients may have, or even a lot of the like specialty machines or devices that they may be using in their lives.
There is a lot of them.
There's a lot.
And you do have to be aware of, at least, if nothing else, what it is.
Yeah.
And what it's doing for that patient.
Yes. But before we get into the episode itself,
Yep.
what do we got going on, guys? Any updates, any cool stuff happening in your lives, EMS related?
Not EMS related, no.
No, you've been having some trouble finding some volunteer
I
shifts.
have been a slacker. It's a fact. I have allowed life to railroad myself out of getting into regular volunteering, which, by the way, you 100% notice the difference when you're not doing it.
Mm-hmm.
Like, the key is to do it more. The more you do it, the more familiar it just becomes more comfortable for you. And I have not been doing that consistently. So I have no doubt the next time I get on the ambulance, it's going to be okay, I need to get back into the swing of this.
Yeah,
For sure.
I've taken a couple of when I was volunteering, there was like a 3-week gap that I had in like February where I went on vacation, then missed a week, and then didn't get on the schedule, and I felt super awkward. But
Yep.
and this is a message to all of you out there. You got to stick with it. Like,
do.
This is a perishable skill. Like the EMT school itself, the stuff that we talk about in these episodes is great. It gives you a huge base of knowledge and allows you to kind of tie pieces together, things that you see out in the field. But if you don't see the stuff in the field, it doesn't click.
No, you're missing a huge part of the equation.
What about you, Jonathan? What you got going on? Anything good down there in North Carolina?
So I'm about to be done with my first contract.
Oh, man.
I went out for 16 weeks originally and ended up staying for like another 22 weeks. And I'm finished with that one. I'm in the process of filling out some applications for some staffing companies and hopefully looking to come to Pennsylvania at least for the summer.
Yeah.
Yeah.
That would be amazing.
At least for the summer.
People, you will be graced with his live presence right here.
Yeah.
Instead
in
of
the blue halo
over there, right here.
I hope we can get it to where it lines up and, everything's, what I need it to be and what the client needs it to be. And hopefully we can do that. And I can rock that out before I start critical care school in the fall.
I'm gonna just throw this out there too. If there's any services out there in need of a fantastic educator who are looking to, maybe bring in a paramedic for their service, we know a guy. Jonathon is looking for contracts. So we need to get him. We need to get him some unique opportunities, especially if you want to throw him on a helicopter. I know that's a goal of his. So definitely just use him. You know.
Yeah, I mean, just throw him in there wherever you feel like you need to. He'll ride on the outrigger if need be. I mean, he's good with that.
Yeah.
Yeah. So that's basically what I've got going on. Hopefully everything pans out. And but in the lapse between starting that contract, I'm gonna stay here at home, and I have some time scheduled to work on the ambulance here at home and work on the response and really get back into some 911 on a more regular basis, as opposed to the IFT that I've been doing, or interfacility transports. So, I mean, which has been super beneficial because I get to see patients for longer and get to see on the backside of you answer a 911 call for them. Well, what happens to them later and what has happened to them since that 911 call is answered. So I get to see some of that. And so it's been super, super beneficial. And I've definitely grown as a provider through that.
That's cool.
But
that's awesome, man.
That's it.
Get to see another side of it. Although, I could imagine just knowing how much we all really kind of resonated with each other when it comes to the 911 stuff. I can imagine that being something that is all right, I kind of want to get back to some 911 stuff. Because
I've tried with my part-time jobs to at least, once or twice a month to stay in some 911, keep my skills up. But yeah, so it just be good to do a train up, if you will, getting back in the 911 swing of things.
Yeah. I have a new experience to share.
Oh.
Something that Max and I got a little taste of it together. We had a volunteer training day at the service that we volunteer at together, and we got to drive in a parking lot with some lights and sirens.
We did,
but now I get to hold one over his head because at my main gig here in town, I've been hired on, and they have me in full on employee orientation. So I'm up in the driver's seat, practicing responding to calls, and it wasn't necessarily planned for me to respond emergently to a call one day, but I was driving, getting some driving practice in. I was with my lieutenant up in the front seat. She's showing me some areas where we have some turnpike entrances, how there's
the slip ramps.
Is that what they're called?
Yep.
Slip ramps, maintenance entrances to the we can use them because we respond to stuff, but that's not where normal cars go, so you don't know where they are.
But it's intended for a fire truck, so they don't have to or ambulance, so they don't have to go all the way around to get on.
Yeah, because the distance between our turnpike exits is
sometimes
25 minutes apart. So she was showing me where those are. So we're all the way on the other side of our coverage area. And all of a sudden we got an ALS breathing problems call. So I was already in the driver's seat, and she's like, well, get there. Okay. So turn that siren on. Of course, I didn't really know how to, because nobody ever tells you how to drive with the lights and sirens. They just say, you'll figure it out someday. And I knew to hit that one button, and I know the switch changes the sirens. So I'm so lucky we had that one training session at our other service, because I at least knew the motions of okay, I'll hit this button, turn the lights on, flip this little switch, turn the siren on, and then I just kind of go. And I will say 100%, and this is no joke, getting to drive through town with the lights and sirens on, made EMT school worth it. I'm just telling you. I did not think I would enjoy it. I'm sorry. There's certain things you just get to enjoy. And while it's nerve-wracking because you don't want to, it's mainly nerve-wracking because I don't want to make a wrong turn. Again, that happened once, but I just like the actual like driving aspect of lights and sirens, as long as you got a good head on your shoulders and you're doing the due diligence or the due regard, it can be a safe process. It's just, some people drive like idiots when they do it.
What I would love to know, because we both did EVOC training together, how is it that you're supposed to constantly keep two hands on the wheels and turn on your sirens and cycle
I don't think that they
horn?
expect you
I
to-
mean,
yeah.
come on.
Yeah, you can't.
You can't. It's impossible.
During transport, it's near impossible. But if you are working with somebody, a lot of times during response, you can have your partner work the siren while you're. Yeah. That's typically how it runs. But yeah, during transport, it's impossible. Yes. But yeah, that whole 10 and 2, and then you're like rotating the the wheel through your hands as you. It's a tough thing to do.
I was one hand on the wheel, one hand on the siren, and one finger on the electronic horn. And I had a really good partner that day. She was reaching up and grabbing. I love the fact that our ambulances have air horns. Like they are.
That's great.
Stupid loud.
Nice.
I guess it's because we're partnered and we're all part of like the fire department basically, or the emergency services department. So everything has air horns, and it's like that gets people out of the way.
It does. It does indeed.
So I just had to share that with all y'all. Like if you've been listening to this and you're like, oh man, what are the fun things? I know people don't talk about it all that much, but driving with lights and sirens on is kind of exciting, at least for the first few times that you do it.
I mean, if you're in school right now and you're listening to this, this is your bright light at the end of the tunnel. Get through the training, get through the classes, get through your practicals, get through your certification, and then you might be able to drive with lights and sirens.
Although, I don't know. I'm sure they probably would have let me go through all this if I didn't get hired. Like volunteers still do that too, especially in different parts of the country. That may be all that's available is volunteer 911, EMT service. So just get out. It's there is some fun to be had in this.
Sure.
But I don't know. I just I figured I'd let you guys know. It's there's some fun things to do.
And I have catching up to do.
Yes, you do. You need to catch up. All right. So tonight's episode.
Yes.
We should probably get into it.
Yeah. And you have a medical term of the week for us?
I do have a medical term of the week. I've actually said it already. We've used it already in the description of this episode, and that is autism spectrum disorder. So in today's world, I would say autism spectrum disorder, or just autism, we might just refer to it by the shorter form of the word, is something that we have a continuing and growing awareness of.
Yes.
Like it is something that I think when I was a kid was not really understood, and we have a better understanding of it now, but it's still so much left to go. Yeah. Like the idea of it being a spectrum, how patients that get diagnosed with autism often can have vastly different experiences and behaviors. And really, I think the thing that we're learning a lot nowadays is that so many people fall onto this spectrum, right? And it's, there's some things that define it.
Okay.
So what is it? Well, it's a neurodevelopmental disorder that affects communication, behavior, and social interaction. It's called a spectrum because symptoms and severity vary widely. So there's a few things, 3 key things that kind of identify it, and things that we as EMTs and EMS professionals need to be aware of in helping these patients have a better day. So the 3 things, communications differences. So they have some different ways that they communicate, that their brains work. They have some differences in behavioral and sensory responses, and One that, some of us are probably familiar with if we've ever known somebody with autism is some social interaction differences. Mm-hmm. So those three things are key to keep in mind. So like from the communication standpoint, you may deal with patients that are everywhere from verbal to nonverbal.
Right.
You may have difficulty having any type of conversation because that just may not be within their capabilities or, something that they do regularly, right? Mm-hmm. They may have limited speech. They may be some verbal. It may be, at a diminished capacity. You don't know, right?
Right.
They may have difficulty in understanding instructions. So we may have to take some different tactics in how we communicate with these patients. What we say and how we say it is important.
Right.
And they may use devices or gestures or even repeat phrases that can either be confusing or not necessarily germane to the discussion that's being had about medical care. Mm-hmm. That can, something that we need to be aware of, like, okay, we need to look past that or around that to get to the discussion at hand, right? So a lot of things to kind of keep in mind from a communication standpoint. Sensory stuff is also big for them. So, I actually kind of suffer from this too. I get hyperstimulated sometimes and I'm like, oh man, I need to get out of this environment, right? I think a lot of people can kind of identify with that sometimes. So sensitivity to lights, sounds, touch, crowds, like all of that can be compounding to how that patient feels in that moment, right? This is the big one because this is one of those ones that we can actually change and we can help with to help make that experience better for our patients. And in those heightened sensory experiences, they may become overwhelmed. There may be agitation or withdrawal, like a bunch of different things in that kind of behavioral response. Or it could trigger like repetitive behaviors, coping mechanisms, self-stimulation, things that really help self-soothe the patient. And then from a social interaction standpoint, we might see things that are, from a typical, interaction standpoint, may be different. So limited eye contact. One of those things that we as humans kind of identify with is our ability to kind of have a conversation with somebody. If they're looking at you, if they're not looking at you, you interpret that differently.
Yeah.
So patients may not have the comfort or the ability to keep eye contact in a conversation, but it doesn't mean what we may think it means. Right. Mm-hmm. So that can be some difficulty in interpreting social cues. Or they may not respond to their name or different commands or requests just because in that environment, they may not be able to process it.
Right.
Like it's just part of the experience. So these are some key things that we have to understand and be aware of for our patients because every patient's different. Though they may not experience all those things, they may have some, they may have all, they may have some different stuff too.
Yeah.
So there's some tips in dealing with patients with autism that we can keep in mind to help the experience, right? So number one being, we're going to call this, by the way, the ABCs approach. Another
one because we needed another one.
We need another one. Another entry.
And another ABC because we don't already have an ABC.
Yeah, it's not the XABC approach. It's the ABC approach of autism. Because we don't have enough acronyms. We just throw more into the alphabet soup of EMS.
Exactly.
So we're going to do the ABCs, which is ABCS. There's an actual S in there. So it's totally going to throw you off, right? So A is awareness. We just kind of talked about it. Us being aware of challenges and experiences these patients might be having. And how it's really a process for us to change our definition, our understanding of what is quote unquote normal.
Right.
Because that is a perception from our standpoint that is not necessarily correct.
Yeah.
So normal is something we need to kind of get out of our vocabulary, really. And we need to treat patients as individuals, right? So, those routine disruptions, changes into the day, new stimulus, that can be something that is very, very big, a major stressor for these patients. And, we talked about some of the communications challenges. And one of the things to really kind of throw in here in terms of awareness is that escalation. Like these patients may escalate if the stimulus isn't stopping, if things aren't going to plan, or if their staff are having some trouble processing this, it can escalate, and that can lead to probably a pretty good word is like a meltdown, like what we see in maybe young children or other forms of expression, right? And it's important for us to remember too that that's involuntary. Like they do not have control over that in that moment. Just like a child, kind of understanding that like they can't regulate their emotions.
No.
And getting upset with a child that's tantruming is really kind of pointless. And
it's counterproductive. You're just going to feed the machine. It's going to keep on escalating.
Exactly. So we have to understand that these patients are not behaving this way voluntarily. It's part of their personality, right? We have to accept them for who they are. And that's normal for them. Right. Yep. That's part of their reactions. So we have to be aware. That's the A. The B is basic. So what can we do to help make this a more streamlined, more understandable process, right? For somebody who's hyperstimulated or has some difficulty understanding what we're saying. So simplifying things down, simplifying instructions, simplifying questions, maybe not layering on double questions, because when we communicate, sometimes we ask 2 questions in a row. Oh, are you married? When did you get married? Sometimes you may throw those 2 things into the same phrase. Maybe take it one step at a time. Use simpler questions to help these patients instead of layering on to things that could be more difficult. Also, one of the things that we can really do is reduce the sensory overload. And this is one of those things that we can help with in terms of, are we in an environment that's overstimulating?
Yep.
Are we around bright lights and flashing, or loud sirens? Can we turn those down? Can we lower the lights? Can we help make this a more calming environment? Yep. So we're going to make it more basic. So then along those same lines, the C is calm. We're going to remain calm. Hopefully that helps make the whole situation a bit more calm. We can avoid confrontation. Like we can't layer in our own frustrations with dealing with patients that we may not understand. We have to be able to remain calm, comforting, and that will help the situation greatly. And we have to be patient, right?
Yeah.
Like we have to be calm. Along with calm is patience, because it may take these patients a little bit more time, a little bit more time to process, a little bit more time to feel comfortable, a little bit more time to help themselves. So it's one of those things that we have to get comfortable with, is the idea of just staying calmer, right? And then, so if those are the A, B, C, there's an S in ABCs, and the S stands for safety.
Yeah.
So this one is really about helping the patient feel safer. So maintaining a familiar environment when possible. That could even include having their caregiver involved, if they have one, a familiar person, a familiar item, a comfort tool, like, Linus's blanket in Peanuts, like not separating from somebody with something that gives them great comfort is something that we should be aware of, right? We should avoid the unnecessary stimulation, not throwing too many things at these patients that can upset them. And then as a last resort, in this kind of safety category is the idea of scene safety as well, the safety for providers, because it would be remiss to not mention that patients who have emotional issues or have trouble sometimes controlling their behaviors, sometimes that can escalate. So as a very last resort, there are things that we have that we can turn to, like partners in, say, the law enforcement space that can be there to help us in terms of safety, or even things like restraints. But again, I can't stress this enough. Those are absolute last resort items that we should never really be going to unless it's truly a like provider or patient safety issue.
Yep.
So,
and it should be guided by your protocols.
Yes, exactly. So that is kind of our medical term of the week, which is the autism spectrum disorder and the ABCs in dealing with them.
Nice.
Yeah. So that I think kind of sets us up for things that we'll be dealing with, because this is just one kind of aspect of patients with special needs.
But you can use this as a tool to approach every patient you have.
Honestly, yeah. I mean, I think any of those things are really good to kind of keep in mind when talking to any patient, treating patients as individuals, and that everybody has their own needs and their own comforts. I think that's a really good kind of mantra for anything, really.
Yeah. And this kind of sets the tone for these patients in general, and the understanding that they're not a different emergency. They're not different patients. They're just patients that you have to adapt to be able to communicate with them and give them the help that they need. It's all the same skills. They haven't changed. You just have to modify how you're approaching it and how you're treating them. And the key principle is empathy. Like have an understanding of what they're going through, of what they're dealing with on a daily basis. That way you can kind of put yourself in their shoes, and that's going to help you approach them better. It's going to help you stay calm. It's going to help you kind of eliminate some of that frustration. Respect what they have going on. Like respect them as a patient. And give them some dignity. If you have the patients that have special needs, give them the ability to kind of preserve that. So they're not feeling like some victim or something that you have to deal with. And that whole mindset is hugely important when dealing with this, because any patient you have is, if you're responding to something, that patient is going to be stressed out. It's just the nature of what you're not there for. You're there for an emergency. So there's going to be stress involved. And then if you add on things like lack of communication, it's just going to pile on straw after straw after straw.
Yeah, one of those things that we constantly come back to, I think there was one of the ones that it was a theme in the trauma section, was don't make things worse.
Yep.
Right? Like our whole job is to try and just not make things worse. This is, from a social interaction perspective, that's really what we're talking about here. Like, we have the ability to not make things worse.
Yep.
So like adding on emotional levels, frustrations,
bringing your day into this case is a horrible idea.
And like you mentioned, the empathy, respect, and dignity. Well, that we should really have that for every single patient. Yeah.
And there's going to be patients that are going to be very frustrating, but it's time to take a deep breath, approach them calmly, and it's only going to make things better. There's a wide range of conditions. You could have physical conditions, whether they have mobility issues, whether they, like we'll talk later on about different machines that they're using for their own self-care that you have to approach and know what they are, know what they do. You have cognitive issues where they're not maybe going to understand everything you're saying to them, or you may have to find a way to get across to them so they understand what's going on. And emotional issues, like Mike was talking about, people that can't cope with the stress, even the simple thing of bright lights in the back of an ambulance. Make sure that you're doing what you can to keep their emotions ratcheted down so it's not escalating things. And also social issues, whether they have the ability to be around people, whether being around a group of people winds up, setting them off, or for that matter, a stranger, an unfamiliar face.
There's, for some people, just being around any individual that they're unfamiliar with causes them great stress. And that is important for us to understand is a thing. It's not voluntary. It's just part of how some people are.
And things that this includes disabilities, whether they have issues with sight, hearing, chronic illnesses that cause them to not being able to be mobile, or that they're dedicated to a machine that's helping them, continue to live. And then social conditions like homelessness, poverty, these are things you're going to have to address. You're going to have to treat them differently. Not treat them differently, but you have to approach the situation differently. And then technology dependent patients that need those things, whether it's a pacemaker or whether it's a ventilator, which we'll talk about later on.
Yeah, there's a whole bunch of stuff we're going to talk about in tonight's episode. But there's, to your point, a whole like range of different, challenges and special conditions that exist that we need to be aware of and that we need to work around, because those are things that again, I hate using this word, are like not in what the quote unquote normal day is for EMS. Although I don't
think that exists.
I don't know if there is a normal day for EMS. There's, I mean, just in this list and my short 15-minute career of EMS, I'm sure you've seen it too, Max, is like in this list of things, I've seen like a bunch of them.
Yes.
Yeah. Already.
Yes.
Like this is just what we do.
Yeah. And disability does have a key definition. It's a physical, emotional, behavioral, or cognitive condition that interferes with a person's ability to carry out everyday tasks, such as working or caring for oneself. So that wraps up a lot of things. And a key point is person with a disability. It does not define who they are.
Right.
It is something that they are dealing with.
Yeah, I think back in the day, and I'm not advocating for the terminology. I'm just saying it has evolved over time with the idea of quote unquote handicapped, right?
Yep.
Like that was what people were referred to, and obviously that has connotations to it that are just not true.
No.
Like okay, there may be people with a disability. They're not disabled people.
No,
they're just people with a disability. Like different disabilities exist. Every person's unique. So understanding that we all live with different abilities and disabilities.
And a term that we keep talking about over and over again in these episodes is advocating for your patient. Like you are there to help them advocate even when they can't. Like you're there to be an advocator for them, whether it's with their family, whether it's with the hospital, whether it's with a nursing home that they're living in. Like that's your job. And then you have developmental disabilities. These usually begin before age 22.
Yeah, they're a slightly different.
They're a different category,
like category than just disabilities in general, because they're ones that happen earlier in life and that then kind of determine quality of life afterwards.
Yeah, and it can be a long-term impairment. It can be there for the rest of their life, and it affects learning, communication, behavior, all the things we just talked about. And this is something that they're living with and going to continue to live with.
Right. So things like autism may kind of fall into the developmental disability category versus something like multiple sclerosis is something that does not fall into the developmental disability. So it's just to know that, like, we may need to approach patients differently depending on how long they've had something, or if it's something that they've dealt with their whole lives.
Exactly.
And there are a lot of things that fall into this category of conditions, right? Jonathan, do you want to take us through this category? Like, I mean, I feel like you've probably, out of the three of us, seen the most of these. Especially in the context of EMS.
Yes.
Yeah. You guys kind of hit it on the head with, even in your short time being in the profession, you've seen a lot of the things I'm going to talk about. And I definitely have seen, I looked through this list as we've been talking and prior to getting on the podcast. And, I can think of an instance where I have interacted with somebody that probably deals with one of these conditions, daily. And so, truly, when we're talking about this subject of dealing with these special populations, they have emergencies just like everybody else, and you're going to interact with them. And sometimes because of these conditions, they may end up having to call, and you may end up seeing them because of some complications related to their conditions. So, we've already talked about autism a fair bit. We won't belabor that. That's just having that level of awareness of that condition. And I think as a profession, as first responders, we're doing a pretty good job of making sure everybody's educated and aware and able to kind of interact and understand some of the limitations with the interactions
Mhm.
with that. So I think we're doing a good job on that. Hopefully we just continue to kind of grow that body of knowledge. But
Yeah.
let's talk about some other conditions that we may see throughout responding to emergencies. One of the ones that I have a bit of a personal connection with is cerebral palsy. Okay, and it's a non-progressive motor disorder, and usually it presents at birth or the early years of development in life. It can cause poor coordination, muscle stiffness, exaggerated reflexes.
Mhm.
Sometimes the inability to walk, maybe even speak, but maybe not, right? So a person with cerebral palsy, or CP for short, they may have normal cognitive function. They just may not have the ability to communicate. So you
Right.
shouldn't assume intellectual impairment when you're dealing with somebody with cerebral palsy.
Right.
Right.
And these folks, if they do have that impairment to communication, they may communicate with their eyes, or they may have devices. Caregivers are kind of an important thing.
Mhm.
And the way that, personally, that's impacted me, my martial arts instructor, my original martial arts instructor, he deals with and was born with cerebral palsy. And
Mhm.
so I learned karate from a gentleman who has cerebral palsy, and phenomenal instructor,
Mhm.
and he's a great example of somebody who's been able to work within his limitations and still have a productive life, and still be able to find something he's passionate about. And it was really foundational for me when I like, prior to my involvement in EMS, being able to interact with him and learn from him. It really set my mindset when I started dealing with folks in the profession of EMS
Mhm.
to really be able to kind of meet people where they are and communicate with them that in a way that's going to be beneficial.
Yeah.
But yeah, so that condition may present. Again, the big things are going to be the poor muscle, the poor coordination, the muscle stiffness, exaggerated reflexes, maybe the inability to communicate in typical ways.
Yeah.
And you can also see some muscle atrophy with these with this disorder. And so you may interact with somebody, and it's just, again, you want to not make the assumption that they are intellectually impaired,
Yeah.
but
Gotcha.
they may take a minute to communicate with. And that's going to be kind of a common theme as we're talking
Right.
through some of these conditions.
Well, one of the ones that I think also falls into this category is like ALS.
Mhm.
Yep.
Or that's Lou Gehrig's disease, right?
Yeah.
Yeah.
So like ALS is an example of something that can help, like, start affecting the body physically,
Mhm.
but the mind still may be there. So
Mhm.
it's one of those kind of things that fall into the movement disorder category, where it's like
Right.
patients may have a disability in terms of how they move, but it may not be affecting their communication or their cognitive ability. So
Right.
it's interesting how those things can really get into a patient's life.
Yep.
Parkinson's disease.
Yep.
That's
Mhm.
another one that kind of falls into this similar category
Yeah.
of involuntary muscle control. And they definitely, all of these kind of conditions can present issues in the instance of ALS. Right, at some point it develops into respiratory issues,
Right.
potentially, right?
Mhm.
And so that's something to keep in mind, right? Because if we're taking care of our ABCs, airway, breathing, circulation, we may encounter somebody that is later in their stages of ALS that we may have to provide ventilatory assistance for.
Right.
It's just something to keep in mind. I think one of the benefits in all of this is usually there's going to be somebody that's a caregiver around, whether that's a spouse, whether that's a family member, whether that's somebody in like a group home type setting, there's going to be somebody that's familiar with that condition. So hopefully you won't encounter this just kind of without knowing that there is this underlying condition.
Right.
But that kind of transitions us into some of the cognitive disabilities, right? Where we would say that these are intellectual impairments. And they come from a couple different sources, right? They can be genetic, right? They can be congenital, or they can have acquired causes, later down the road.
Yeah, like head trauma or TBI.
Traumatic brain injuries. Yep. I've interacted with several folks over my career where, they had a motor vehicle crash and, by all means, they had a typical life before, and now they have these challenges because of that traumatic brain injury.
Right.
And it, as we've talked about, it can affect communication. It can affect their ability to learn and maybe making choices. And there's it truly is a spectrum of what somebody's capabilities are.
Right.
Following one of these cognitive disorders, and you're going to see folks that are very, very highly functional, and then you're going to see folks that are a little bit more dependent on some care that's provided to them.
I think one of the conditions that also falls into this category is like Down syndrome.
Yep.
And I've had the pleasure of meeting several people in my life that are awesome and have varying levels of ability and independence with Down syndrome. So it's one of those things that's like, you not everyone fits into a cookie cutter, example of a condition, right?
Yeah. I have a really good friend who wound up having a head injury, and as a result, has like a 30-second memory. So he went from being a fully functional individual that was running a contracting company to, if you talk to him in 30 seconds, he's going to start repeating himself. So,
yeah. One of the cool things about this profession is a lot of the time let me just say throughout my career, a lot of times talking about individuals with Down syndrome, a lot of times they love to come by the EMS station or the fire department. And so I've gotten some pretty good hands-on talking with these folks in not necessarily an emergency environment, which has only like built my comfort level. I have one guy here local, he'll stop by the firehouse and he will, he told me a joke one time. And I mean, he really caught me with the joke. It's not appropriate for the podcast, but he caught me with the joke. And so now
it may not be appropriate for the podcast, but it's probably appropriate for EMS.
Yes,
100%.
Mainly because there's really nothing that's not appropriate for EMS.
There is no line. It does not exist.
But since that first interaction with him where he told me the joke and like he just made me roll with that joke, he tries to tell me a joke every time I see him now. And so it's great. A lot of times they want to come check out the trucks and super happy to be around and super happy to learn all about the firehouse and EMS and all that sort of stuff. So hopefully as listeners, you guys will get to interact with some folks like this, because it is a pleasure to talk to these folks. But that's just an example of a cognitive disability or cognitive impairment.
Well, there's some physical ones too, right? Like, so like we've been chatting about, like some developmental disabilities or neuromuscular disabilities. But like sometimes you might have just, like these things that are kind of in our heads linked to sensory or physical abilities like hearing or vision, right? So what about those?
Well, and that's kind of the thing. As we interact with folks, as people get older, the hearing that we are born with is the hearing that we have. And if we're not careful, we can damage our hearing. So we may have folks that, they were living typical lives and they had something happen, or through constant exposure to overly loud stimulus, it degrades their hearing.
What'd you say?
Then they're, Then there are folks that that maybe they're born with a condition that that causes their hearing not to be developed.
Right.
And,
Right.
so there's different aspects of that. One of the things that deal with pretty frequently is older folks who their hearing has started to degrade, and so you may have to talk a little louder, not screaming at them. That's I want to emphasize that, not screaming at them, but you may have to talk a little louder, or maybe they may have a better ear that hears a little bit better, so you may have to look directly at them.
I'll throw this one out there too. My mom just recently wound up getting some new ability to hear. So sometimes just gently reminding someone like, "Hey, are your hearing aids on?" Can really help the situation.
Yeah.
Right. And that can be a benefit.
Yeah.
I've dealt with numerous people that have hearing impairment, and they speak sign language, speak American Sign Language.
Yep.
And so sometimes that requires us to, if we aren't aware of American Sign Language, that requires us to find an interpreter line.
Yep.
Usually that's going to be a visual thing, or those folks can read lips. So we may have to approach and be straight on with them, facing them, so they can read our lips. I actually ran a call where a gentleman was riding a moped and he was struck by a car. And so he was deaf, and then his partner was deaf, but she was signing for us. She could read lips, so she was signing for us to him what we were asking, and then he would like sign back to her. And so she ended up riding to the hospital with us as we were providing care to him, so we could communicate.
Right.
And we actually put
Being
her
an interpreter.
Yep, as an interpreter. So these are things that we can and we will probably see.
I'll throw this one out there too. Remember before we were talking about pens?
Oh,
You could just write a letter or like write out the question for a patient and have them write back on the
100%.
paper. Finding different solutions to these problems. It doesn't always have to be like, why can't they understand what I'm saying? Okay,
right.
well, let's,
Next week's tool of trade, the pen.
Well, and I've been on some ambulances that have had some dry erase boards, and
exactly.
Those have been
awesome.
great options for us in those instances. Hearing impairment can lead to some limitations in communication, but you just have to adapt to that situation. And again, it could be partial or complete hearing loss. It could be that congenital thing, that trauma-related thing, age-related thing, or that exposure over time. These are all ways that somebody could have hearing loss.
I have no idea why I don't hear anymore after all these years of listening to loud music and gunfire.
Right.
It's unclear to me why my hearing is now not as good as it used to be.
I have no idea why I can't hear things in that like 200 megahertz range. It's just I don't know. It's just for anybody out there, by the way, hearing loss is cumulative.
Yep.
It is.
So you lose a little bit at a time. It does not come back. So just wear earplugs and don't if you go to rock concerts, stand in the back. All right.
Well, and I'll say this for us in EMS, fire and EMS, and law enforcement as well, right? So we've got sirens blaring, sometimes right over top of our heads. That air horn you were talking about at the beginning of the podcast, that's a great tool for us to stay safe.
Sure.
But what's the damage that we're doing to our own hearing depending on its placement?
It's
100%.
worth it. It's all worth it.
But here's the cool thing, just related to that. A lot of like fire engines and some ambulances, I've seen it more in fire engines, they're putting in communication headsets that do provide some level of hearing protection. So if you have that option, you should be using those as a provider. Let's change paces for a little bit and talk about some things that are more that we would think more related to medical issues, right? Now, these are all medical issues, but like we would maybe interact with these folks on a regular basis. We wouldn't necessarily, at first glance, consider this a special population, but this is something we're going to deal with. And one of the conditions is kidney or renal failure.
Mhm.
Right.
Yeah, people on dialysis, or maybe they're not on dialysis yet. All right. Maybe they do at-home dialysis, which is peritoneal dialysis, or maybe they go to a dialysis center. These are all potential things we might deal with, and really, what it comes down to is a loss of kidney function
Mhm.
due to it can be traumatic injury, but usually it's going to be related to other medical issues we have going on,
Right.
or it could be exposure to certain chemicals in our body that cause damage to the kidneys. And this can be a chronic disease process that is cumulative, or it can be, again, something caused it. Dehydration can be a large cause of renal failure or kidney injury. And in the way that we talked about hearing loss, it can be cumulative,
Sure.
right? So
Right.
your kidneys only have a certain amount of function, and when that function starts to degrade, it can lead to renal failure, and
Yeah.
there's different stages of that as well.
I think
So-
one of the things that always stood out to me about this, like this is a special population, like the thing that's like, and special populations in general is like, oh, when you hear this, you should immediately start thinking this, right? Like,
Right.
the indicators and stuff. And I didn't mean to interrupt you, but like the idea
No.
of making sure that when we find out patients are on dialysis, always asking like when their last dialysis
Yep.
was, like, are you overdue?
big.
Are you, is it supposed to be now? Are you missing it? Like, when was your last one? Or like, the ports in general, like
Yeah.
how they
Yeah.
may pop up
So-
or like be used, and they may have to switch. And like those things are delicate sometimes, and they can lead to problems, infections, and or bleeds. So it's one of those things of like, oh, well, it doesn't immediately, like you said, pop up as a special population, but it's like, no, it's a population because we have these unique challenges that exist for this
Correct.
Yeah.
for this set of people.
Yeah. And just to talk a little bit more about these folks, if they have missed dialysis, or a lot of them are on fluid restrictions and like lower sodium diets and things like that, we really run the risk of encountering a metabolic imbalance.
Mm-hmm.
And so that can throw their entire blood work off. That can cause them to be altered. That can cause potentially cardiac arrhythmias. There's a lot of different factors to consider with those folks in renal failure.
Right.
One of the things we're going to talk about, Mike, you were talking about access for dialysis, right? So fistulas, we want to avoid doing any sort of blood pressure or procedure on a fistula limb.
Mhm.
And sometimes that can be tough because sometimes they have fistulas in both arms. And so the best question to ask is, which fistula are you actively using?
Mhm.
Right.
It can be a tough thing. But yeah, so again, these folks, you're probably going to see a fair bit of them. I see a fair bit of people that are in renal failure quite often. And again, they may have an altered mental status because they haven't been dialyzed in a recent time period.
Mm-hmm.
We already touched on our neuromuscular disorders, but let's just hit the highlights real fast in relation to those. So these are disease processes that cause muscle weakness. Again, ALS could be one, multiple sclerosis, muscle dystrophy, muscular dystrophy could be one as well. Typically, and Parkinson's as well. Typically, these can be progressive or they can flare up. They could be intermittent. There is a significant risk of respiratory failure, right? So you may have to provide, if their disease process has progressed far enough, you may have to provide that ventilatory assistance like we talked about before. And they may have communication difficulties.
Right.
Due to not having any control over their muscles. So it's just these are things that we're going to encounter.
Right.
Something along that line, right? It's not necessarily a muscular thing, but it does deal with the neurological system. Is strokes and
stroke victims.
We are in this instance. We're not necessarily talking about the new onset stroke.
Mm-hmm.
But the after
we're talking about the aftermath when people are left with deficits.
Mm-hmm.
Yeah.
And so they may have, and just to cover again, a stroke is a brain injury caused by different things. It could be occlusion. It could be a bleed. It could be several different things. But the big thing we need to understand is there could be deficits after this person has had a stroke.
Right.
Yeah, absolutely.
And
I mean, they could be really like it's very similar to what we were talking about before with TBIs, right?
Mm-hmm.
Like any damage or injury to the brain can lead to these other types of cognitive disabilities, right?
I mean, a lot of times it's a communication deficit where they can't say what they want to say.
Yeah.
right.
Even
Or they
sometimes can't even write what they want to say.
They may have slurred speech because of the deficits after the stroke. It may not have the greatest ability cognitively, right? So
a lot of motor things.
The motor things too. Yep.
Yeah. So it's and a lot of times, as we're talking about, especially some of these neuromuscular and post-stroke things, we have to consider this person may not be able to assist us in getting them out of their residence or wherever they are when they call 911. So we may have to account for that as we're trying to get them to the ambulance.
Right.
And that may even mean, hey, maybe they can't appropriately sit in a stair chair.
Right.
So just all sorts of things related to that. One of the other things is spinal cord injuries. We talked about traumatic brain injuries, but spinal cord injuries, that's another category. Typically, people are not born with this. This is some sort of stimulus has happened to cause a spinal cord injury,
Right.
and it's generally leads to a loss of motor or sensory function below the level of injury in the spinal cord, and it's all going to be dependent on the severity of that injury as to kind of what their baseline is, and what their capabilities are after said injury. If you've got high spinal cord injuries, you could even have somebody that's dependent upon a ventilator, because they're not able to breathe on their own. And one of the issues with spinal cord injuries after somebody has one and as they progress, these folks, because they're not moving around as much, maybe they're bedladen, they may get pressure ulcers or pressure sores due to staying in bed and not being able to move, they can also have some skin breakdown because of that, and because of maybe not having control of their urination or their bowel movements. And so, somebody unnecessarily sitting in those waste products can cause skin breakdown as well, as well as blood pressure instability. And what we have to consider is when we've talked about shock in the past, neurogenic shock, right? It usually is caused by some sort of spinal cord injury. And so the long-term effects of this spinal cord injury is some of those signs of neurogenic shock, right? They may kind of
persist.
They may just have them hang, when they're hanging out, right? So these are things to keep in mind when we talk about spinal cord injuries. And then one final thing I want to talk about is visual impairment.
Oh,
right?
yeah. That's a big one.
Yep.
Yeah. Again, as I looked through this list, there's not, over my career, I've seen multiples of all of these kinds of patients, some more than others. I see the renal failure one a whole lot.
Yeah.
But I've definitely encountered some people with vision impairments, and those can be partial,
Right.
or they can be complete losses of vision.
Right.
And then sometimes those can be progressive as well.
Yep.
That's one of the big things, is that their vision starts to fail, and it just continues to get worse and worse and worse as time goes on. So,
and it could be maybe not something that we typically think of too. Like hearing, we mentioned that a patient may have a good side or a bad side. Eyes come in pairs of two. You might have certain eyes that have, like one's better than the other. You might have patients with a glass eye or a fake eye.
Sure.
Where like if they're turned a certain way, they can't see you. Right. Like, so those are the things that like also kind of fall into this category of special things, like things that we need to work around to work with our patients. Right. Like, oh, well, maybe sitting on the other side, just like you would for talking into a different ear, may be what we need to do for this particular patient because they can see better.
I have dealt with some patients that oftentimes, or I shouldn't say oftentimes, but I've dealt with some patients that sometimes will have multiple of these different disorders and issues that we're talking about.
Sure. Yeah.
I regularly answer calls for a fella that he is blind, and he also has a seizure disorder, and he also has cerebral palsy on top of all of that. So he really, we really have to change our approach when we're interacting with him.
Yeah.
And we really rely heavily on the caregiver to kind of tell us what's going on and what they've noticed. And oftentimes the caregiver will ride with us during this transporter interaction. So
yeah.
Yep.
And we'll talk about caregivers in a little bit too, because I think they're so important in this process, in helping with patients. So, but yeah, vision's that big one. I mean, we as humans see like, or we absorb 90-something% cognitively about our environments through our eyes.
Yep.
It's terrifying to me, the idea of being blind. So empathizing with these patients and understanding what they're going through. And then, I think one of the tips that they had in the book was always making sure that you're telling the patients what you're doing.
Yes.
Like verbalizing it and talking them through, especially in that instance where they can't see you, can be a huge comfort for them and help them understand what's going on with their environment. And that's really one of those things that we can do for them.
I mean, just the simple thing of letting them, hey, I'm going to be touching your shoulder because I want to see if there's something going on there. And vocalizing that. You should be doing it anyway for all your patients.
Yes.
But in that particular case, especially, you have to, because you have to empathize with what the world is that they're dealing with.
Yeah.
And if you have to pay special attention to that.
Exactly.
Yeah.
Cool. Well, yeah.
Yeah, I think we've got some other groups that we can talk about. We've kind of covered a broad range of issues, but there's some even additional groups that maybe don't have specific things that we can point to conditions wise, but there's some groups that we might want to take care with as well. Right. You want to run us through that?
Yeah, because I think what you brought us through was patients with either conditions that are specific to health. And there are some special populations that exist that are maybe socioeconomically, unique, or unique in in what stage of life that they're in. So it's things that aren't necessarily specifically health related, although it's all connected. So there's a few of those that really stand out. So one of the big ones we learned about was terminal illnesses. I know, and this really ties into with things that we look for when we're going out on EMS calls too, is anytime we're coming across an elderly patient or somebody that is, of advanced age. And, we're always trying to be cognizant of the like DNR orders, or like what's the term I'm thinking of? Not a DNR, but a
Advanced directive.
Advanced directive, like you know, some sort of paperwork saying what they want to do with their health.
Yeah.
Or asking if somebody's like a medical power of attorney. You know, basically trying to make sure that we understand the situation, what they want done, so that we're not going through heroic measures, because these patients with a terminal illness may have made the decision at that point to kind of gracefully exit.
And it very well may be their only form of control over what's going on with them.
So like we're talking about patients that could have cancer, COPD, you know, these kind of debilitating diseases that really kind of degrade quality of life. So they may have made the decision at that point to kind of, you know, hey, we're going to let this progress, right? So typically they may have things like hospice care. So dealing with either nurses or hospice attendants, which may not be, you know, it depends on provider level and all that stuff, but they may be at home hospice. You may be responding to somebody that's not an at-home hospice. And basically the kind of thing to keep in mind for this particular population is you may feel like, well, what are we supposed to do here? Because if they're at a point where they have an advanced directive and they're like, hey, we want to kind of, you know, we want this to progress, but we don't want heroic measures. We have to find that right balance between, is this the time for us to intervene? And we have to go by their cue on that. It's like, okay, yeah, we're gonna help because there hasn't been anything defined yet where we don't intervene, right?
Exactly.
So just because, and I wanna say this, just because somebody's on hospice care or end of life care, doesn't necessarily mean we do nothing.
Exactly.
As providers. Their issue that they're having may not be related to the condition that has placed them on hospice.
Exactly.
Right.
And
so.
Like say someone falls and has some trauma, like a broken bone. It doesn't mean that we're not going to help them with the broken bone because they have cancer, right? Like, and that may even be one of the things that leads to why they have the broken bone, because they have, you know, bone loss or things like that. So we're definitely going to, you know, provide care, even though it's, you know, this patient has kind of chosen to be, you know, at the end of life, right? So that's one of the big things to keep in mind. And you may also see things in this population where they may be heavily medicated. You know, they may have pain medications. They may be on opioids. There may be some cognitive, you know, issues along with that because, unfortunately, one of the side effects of those types of drugs is like that kind of diminished capacity, right? So it may be harder to communicate with patients that are in that state.
Right.
But yeah, the big thing is we want to respect the patient's wishes. We want to provide emotional support, respect their decisions. Like that's the common theme of this episode is definitely treating the patients as individuals and having respect for them. Right? And then you know, again, we keep coming around to this topic too: is family members can be, you know, make or break in these types of situations.
100%.
So relying on them for information and for guidance and for, you know, an idea of what that patient's baseline might be are all really great things to use to your advantage in that type of situation. So, you know, along with that, so like this is patients that are in kind of end of life, right? Like it may not be a specific disease that we're there to help for. We're there for maybe something different. Another type of category that falls into this is obesity, or the technical medical term of bariatrics, of which, fun fact, I just double checked, I am, you know, still in the obese category. I think it's anybody with a BMI over 30, which is an arbitrary number between height and weight.
Yes.
So usually it goes into categories of normal, overweight, and then obese. And that particular patient set can have some unique challenges, right? Along with certain diseases that are going to be kind of linked to that lifestyle, to being obese, like diabetes, or, you know, congestive heart failure, or a high blood pressure. Like these are all the things that are they're just inherent with being overweight, right?
Yes.
I heard it my whole life. I've been overweight my whole life. They're like, hey, you need to lose weight so that you can lower your blood pressure. By the way, lowering your weight does lower your blood pressure. I can speak and I can attest to that. But you know, there's certain challenges that we have in this category. that aren't necessarily just those kind of typical presentations of conditions that happen with being overweight. So airway management is a big one because
Absolutely.
basically the human body is not really meant to have that much weight on it, and it has difficulty maintaining an airway when things start getting weaker. So laying down on your back can be a problem for overweight patients. They can have orthopnea, which is, basically the body's own weight working against it and being able to breathe. Right. They just don't have enough muscle strength anymore to push up against it. So that's where we're immediately considering things like a semi-Fowler's or a Fowler's position, so that the patients can have an easier time breathing versus, say, a supine position. It may be difficult to ventilate these patients if we need to do positive pressure ventilation, because of how difficult it is anatomically to get the head moved, to have extra, basically muscle tissue and things around the neck area. Those are all things that can cause additional complications. So things that we need to be aware of in terms of maybe being a little bit more, I hesitate to say, forceful or like maybe firm with making sure that we're putting the effort in to manipulate the patient's bodies to be able to get the anatomy, like for a head tilt chin lift that we needed to do, right? We need to get a full head tilt chin lift, and it may be more difficult in an obese patient.
And I have on several occasions ventilated people in that semi-Fowler's position, right? We, a lot of times when we're doing like CPR and that sort of thing, we've got somebody laid in the supine and we're providing compressions and ventilatory assistance. But this is an instance where we may want to set them up and then assist with ventilations.
Right. And then I think the big takeaway, though, of the obesity and bariatrics story or patient population is movement, is transport. I've even experienced this probably once or twice in the 5 or 6 months that I've been doing EMS. And that can be a real challenge, especially in confined spaces, places where, it's in between a bed or a wall or, around the toilet, in the shower, especially a small shower. Like, those are very difficult situations to move patients in general when that patient is overweight, or sometimes even into that category of like, you'll hear of patients who are like 600, 700 pounds that are completely bedridden, and that they need to have specialty teams come in to help them out of their own apartments. And those are the things where it's like, we may encounter that, and we still need to provide great care, and we need to come up with a plan on how to move these patients. So using proper tools, like, a reeve stretcher, great for a lot of different patients. But this is where you need to start thinking outside, like, oh, well, we're not going to be able to do this with just 2 providers. Let's get the fire crew over here.
You have to make sure
more
you
people
get
on this.
Yeah, you have to make sure you get enough hands on the job.
And not only just the equipment itself, but even the form of transport. Like certain gurneys have a weight limit on them.
Right.
So you may be exceeding that with certain patient types.
Right.
So that's why certain, like some services or some areas have bariatric ambulances.
Yep.
So you may need to call out to your dispatch or your county or your supervisors or your medical command to ask these questions, to say, hey, we have a unique situation here. We have some limitations. What can we do? What do we have at our disposal? All these things exist that we have to keep in mind for patients that are a bit different of a challenge than what we usually have in moving.
Yep.
Sure. I have a question for you guys related to that. Does your 911 call center have emergency medical dispatch, and is asking patient weight a part of that process for you guys?
In Lehigh County, I don't know about Bucks, but in Lehigh County, we do not get weight information.
Yeah, I don't think we do at Bucks either.
But that doesn't mean they don't ask it. It just may not be one of those things that usually gets flagged, because if they do ask, and like I would imagine too, if a patient is disclosing that, like, hey, I'm this many pounds or whatever, they'll probably put that within the call notes.
Yeah.
But
Sure.
I don't think it's one of the ones that's in like the form field of like, patient
I've seen it
information.
come up on the CAD once, I think, but it was just they happened to have the information. I don't think it was a thing of like an intentional thing. It just they had the information or it was given to them.
There are some dispatch centers that do get that information, and depending on where you're at, they will go ahead and flag that call and dispatch folks as appropriate to provide additional assistance. I know locally that we've done that with some patients that we know we're going to need assistance, whether it's due to weight or whether it's due to complications of getting in and out of the residence. But yeah, that's just an additional aspect, like you were talking about, Mike, you got to be aware of.
Yeah. And by the way, for anybody out there, anytime you see the word bariatrics, that is the medical terminology for obesity or dealing with obese patients. So that was something I didn't really learn until just a couple of years ago, that's what that meant is bariatrics is like, if you see a bariatric ambulance, that's for bariatric patients. See how like it's kind of like it's not necessarily the disease or the condition itself that's defining these populations. It's kind of like the extra thing around it. Another one that really falls into this category is homelessness and poverty.
Yeah.
And while, again, this is one of those populations that doesn't have a specific complication or a specific thing that you can point to for it, but it is an indicator for a bunch of different things.
Yeah, and there's a good chance you're going to have a lot of things going on.
Yeah, like so certain health risks are usually automatically kind of associated that we should be looking for when we're dealing with people that are homeless, or is the term now unhoused, I think is usually the kind of the proper term nowadays. I don't know, but
I'm not sure.
Yeah.
But at any rate, somebody that is housing insecure.
Yeah. Because even those that are maybe not fully secure in their housing can fall into this, like those that suffer from poverty. While they may have a place to live, but they may not have nutrition and and access to health care that allow them to be as healthy as they could be. So the health risks in this category are things like, number one being malnutrition, which leads to a lot of other kind of downstream effects too, but definitely malnutrition or undiagnosed and uncaught chronic diseases or chronic illnesses. So things that are maybe even communicable diseases. I know tuberculosis is one of those ones that has a huge like homeless and poverty like population just because it's one of those things that is very easy to transmit, especially in close quarters with other people that have tuberculosis. But it's also one of those things that, you have to catch it to be able to treat it.
Right.
So that's one of those ones. Mental health issues also very closely linked to the kind of populations of the unhoused and poverty. And, those may even be compounding factors for them being in that situation in the first place. They may not respond, to healthcare providers. They may not like going to, kind of conforming to the standards of society. So like all of those things kind of compound into the situation that they're in how they're, they may not have access or be really willing to kind of, get the help that they can get. So those are all factors, but also one of the big ones in there too, unfortunately, part of that story is substance abuse.
100%.
Which can be anything, all different types.
Yeah.
We don't even have to go into the different substance abuses, but
it could be the cause or it could be a byproduct. Yeah,
it could be like those can be forms of self-medication from the other things that exist. And unfortunately, along with that, like, especially things that deal with needle exchange, you have a compounding factor again with certain communicable diseases that are bloodborne diseases from sharing needles and other intravenous drug use. So all of those things exist in this kind of category. And they're things that as healthcare providers, we have to look out for and be aware of. And we wouldn't be serving our patients if we weren't actually kind of, guiding some of the conversations to that. Like, hey, when was the last time you ate? How are you? Are you, if you're talking about how well they're eating, like what's your bowel movements been like? Are you drinking enough? Are you dehydrated? So those things can really kind of tell the story of like how that patient is doing. So, it's their conditions, but also really part of that, like the big thing in that story too, is how they have limited access to resources that can help them.
Yeah.
So access to healthcare, access to healthcare providers that can then respond to some of those things that their symptoms they're having and other things.
And you may be that medical contact,
right,
that only medical contact that they receive. And I think, with the bariatrics and homelessness, it's really important to be respectful, to give them some dignity because there's going to be shame involved with both of those situations, of some kind. So, giving them that bit of dignity that they may not have had in a recent time and being that for them. And again, with the homelessness or unhoused, being that medical contact for them so that they can get help.
Yeah. So it all ties into that thing that we were talking about before in terms of like, we really should be treating these patients as individuals. We should be giving them respect. We should be, treating them for who they are, a human, and what we can, what can we do for them today?
Yep.
How can we make their day better? Right. I think that's I think a really good mantra to kind of keep in mind.
One of the things, Mike, I would challenge our listeners to do is to figure out what locally the resources are available for these folks.
Sure.
And maybe even make a list and
have it available.
Make that part of their interaction with these folks. Because sometimes people just aren't aware of the resources available to them.
Right.
So those are some of the populations. One of which to kind of touch on briefly is children and infants, and not necessarily just children and infants. We've talked about kind of pediatrics and children, and that's a category into and of itself. But basically any of the children or pediatrics that fall into any of the conditions that we've talked about before, whether it's developmental disorders, cognitive disorders, metabolic disorders, like these types of things all compound. And then when you see them in children, it's makes it even harder, right? So you might see common conditions with children that have these kind of disabilities where you may see them maturing even slower than other children. They may have like prematurity. They may have things like congenital heart defects or like things that basically really affect their quality of life. Mm-hmm. There may be neurologic disorders, all the things that exist in the adult population. Obviously they exist in the pediatric population because they had to be at that age to get to become an adult in the first place. Right. So, they all exist. Now these children, they're often, technology dependent. And I'm not talking about like they need their iPad. That's my daughter.
That's a whole other thing.
I'm talking about like, they may need a ventilator. They may need their like a special chair that they can use to get around. So those are things that are very important to these patients that we should be accommodating to and trying to make sure that they're not being separated from, because that's part of their quality of life is these pieces of technology that they've become dependent on. We're going to keep coming around to this topic of like, caregivers, especially parents in this instance are your best resource. I guarantee you for children of special needs and special populations,
all the information.
They are the subject matter experts usually in their child's healthcare, in their treatment, in their medical history, their history of present illness, past illness, past pertinent history. They'll know what they ate. Yesterday, the day before, they probably have a log of it. Like, parents with children that fall into this category are usually incredibly dedicated and probably like, in line for sainthood.
100%.
So, they are a great resource. And, they'll also probably have all the things at their disposal that they know, because usually it's not their first rodeo. Unfortunately, with children who are in this category, they wind up going to see the doctors a lot. They may go to the hospital several times a year. So things that you just want to make sure that are there is like any medical forms, any information packets, cover sheets, medication lists, the things that we ask for from most patients. While we may not immediately think of that for children, usually we should be making sure that we're coordinating with those parents in those situations to make sure that we're getting as much information as possible. But yeah, so those are some patients in like in some populations that aren't necessarily directly related to their condition, but their lifestyle or the world around them that kind of put them into a special patient population. And all of those, all the things that Jonathon has gone through so far, those patient populations, and things that we're talking about in general tonight, all kind of fall into this category of how, things that we may not approach the same way that we approach every other time. Like these are all things that kind of make us go, hey, let me think about this. Let me approach this as an individual, because it may not be what I'm expecting or something like that. And really that kind of falls into a methodology, right? Like there are some tips and tricks and guidance on how to deal with these types of populations. And we'll go through those real quick. And then I think we have a few other special situations like dealing with medical devices, because those are a whole nother category into themselves. Because we as EMS professionals, sometimes we get presented with these tools or devices that we're like, oh, we didn't even know this thing existed. Yeah. So all the stuff I'm going to talk about here are actually really good tips for all of those things. Mm-hmm. Patients with special conditions, but also patients that are reliant on special devices.
Sure.
So really the crux of this revolves around a core idea that as EMS, we typically respond to the emergency, right? That's what usually we're thinking of when we get there. And these are the situations where we get there and go, oh, there's this other compounding factor that I was not expecting to be something that I'm dealing with, right? Like it's either patients with a cognitive disability or some sort of physical disability that it's like, oh, well, what thing do I now have to work around, right? And that pre-existing condition can really complicate and sometimes overwhelm us, and it's okay to recognize that. It's okay to say, okay, I'm feeling overwhelmed with this. How can I kind of coach myself to work the problem, right?
I mean, it's better to recognize it. That way you can kind of get past it.
Yeah. Like what, and I would encourage people to kind of use the mantra, one of the mantras that's very common on our podcast of like, what's important now? Mm-hmm. Like which one of these things can I focus on to work right now? Because, that may be one of those things where is it important for us to even get distracted and get deep into a patient's past, disability, or do we just need to worry about the issue that they called us for right now? Right. Is it that pertinent that we're like, well, let's focus on that. Let's focus on a life threat. That may be the right answer, right? Correct. So we have to really evaluate each patient's individual needs. We need to treat them like individuals, and we need to identify the problem that made them call 911.
Sure.
Because that's why we're there. Something about their day has changed, that it's different than every other day that they have. Their normal may not be what we think of as normal, but there's something that's changed, and we need to figure out what that is. And that's what we're there to help with, right? So there's some interesting and different challenges that we may run into that aren't necessarily the patients themselves. So one of which, like all the conditions that we've talked about, can exist in different environments.
Right.
That's one of the things that kind of blew my mind about this. I always thought like, every time someone calls 911, we're going to like respond to a quaint little house. It's going to have like a walkway up to it, and there will be a driveway, and there'll be a front door, and or on a rare occasion we'll have to go to like, a business, because sometimes people get sick at businesses, right? It's way more than that.
Yeah. That would be lovely if that's all it was.
Sometimes it's churches, sometimes it's businesses, sometimes it's sporting events, sometimes it's in the middle of a field.
Trampoline park.
Sometimes it's on the side of a road. But one of the ones that I know I've responded to probably more than any other, more than homes, is like skilled nursing facilities, nursing homes, specialty rehabs. And we may even get calls to things like mental health facilities or halfway houses or, basically, residences where there are helpers or people that have these special types of conditions that all live together that we have to then learn to or experience and figure out how to help them.
I mean, the hope is that there's a caregiver there, whether it's a nurse or family member, whatever it happens to be, that can help you get started on figuring out what's going on. But the reality is you may not have that.
Yeah. Well, we'll talk about caregivers too, but the facility itself, there are things that you should know. Like in your locale, you should know the facilities, right? Like the different types of places you may get called to, where there may be, like if you get called to, I'm going to make up a word, like, St. Christian's Academy. Well, that might be a youth mental health facility.
Right.
Well, if you get called to St. Christian's Academy, all right, well, that can influence your pregame. It may influence where you park your ambulance, what type of procedures do they have that are specific to that place. You should probably get in the habit of learning, where their entrances are, where the best place to go is, who you should talk to, who the charge nurse is, if there's a nursing facility, these things that if you go there a bunch, coordinating, making good relationships with the people that work there is pretty key to success.
I mean, some of these facilities are mazes. They're absolute mazes, and learning how to get through them can make your job of getting to the patient and getting the patient out if you need to much easier.
Yeah. Just knowing the floor plan is huge.
Yeah.
But another thing to keep in mind with these different types of facilities is that patients may have individual plans based off of their special needs.
Right.
So you may have patients with dietary restrictions or like behavioral restrictions, or hey, if this patient experiences this type of stimulus, we can't do this, or they can't be transported. There's a lot of different possibilities that can be in this type of situation, but it's important to know that you want to have that discussion with the facility and know that patient may have their own individual plan that will help give them the best care possible.
Yep. And knowing the staffing for these facilities is huge because that's your cheat sheet. If you have those people, that is your fast track.
Well,
hopefully,
sometimes you have facilities that don't have the best staff, but
yes,
we've seen that too. I mean, the whole gamut of EMS is like sometimes dealing with facilities that you're like, oh, that place. Not because of the people, like the patients, but because of the staff.
Yeah. They have a registered nurse. Okay.
Yeah.
It can be a difficult thing to deal with. Now, on the higher acuity side of things, when I've went into some of these facilities or these like group care homes, usually those places are pretty good about, conveying information and knowing what we need and telling us where we should park and that sort of thing. But yeah, you're right. You see the gambit of all sorts of conditions and situations and
Well, that actually brings us really well into something we've been dancing around so far, and that is the idea of caregivers, right?
Yep.
So the facility itself is a caregiver, but the idea of caregiver can be more broader than that, right? So patients with, parents of patients are caregivers, spouses, anybody who's there to be an aid or a benefit to a patient's life is a caregiver, right? And by far in patients with special needs, and I actually know this story a little bit and kind of resonate with this because this is a huge aspect of all healthcare, not just EMS, but in my past experience doing pharmaceutical advertising and stuff, like, recognizing the important role of a caregiver is very important in the story of every patient, right? So these caregivers often are the most knowledgeable and best person to coordinate and get information for patients with special needs.
Right.
They know way more than you do. Like, I would bet 9 times out of 10, that person who's a caregiver for somebody with some sort of chronic illness or a disability knows way more about that specific thing than you ever will. They might even know more than doctors do on that one very small particular topic. The flip side of that is, your job really well. You know how to be a good EMT, or paramedic. You know how to assess patients. You know how to transport. You know how to make decisions. You know how to do the job of being EMS. And the trick is making those two people work well together, and be synergistic with each other instead of trying to
bash heads.
Yeah, confront each other. It's like those two things can be very powerful together. But they know the patient, especially the conditions that they're dealing with, or more importantly, they know their baseline.
Sure.
Like things that would be impossible for us to know when we get there without their input, especially for patients that are like nonverbal or have cognitive issues or communications issues. Like we would not know showing up on scene if somebody is non-communicative or having an altered mental status.
Right.
That is very difficult for us to figure out just from meeting a patient. But having that caregiver there to ask the questions like, hey, is this so-and-so's baseline? Are they usually like this? And they go, oh yeah, this is totally normal. They're like, this is how they normally are. Great. Awesome. So we don't like, that is something that is not a red flag right now, because we don't have to say it's something that has changed. What might be different today? Oh, they are limping around. They never limp. Like they are having pain in a place that we cannot figure out. So, okay, well, great. We start narrowing down where we're having trouble, right? And that's something that we may never have known, because like we may not pick a limp up as something that's like, oh, that's their problem. Well, that could be something as complicated as, oh, they're about to have an appendix that bursts because they're limping around. They have trouble walking. You know, like that could be presenting in terms of like them not being able to walk well. So like those things. Like having that caregiver there, absolutely critical and a blessing, for knowledge, for things that you want to know. And talking about devices before too, like patients that have specific devices or things that need to keep with them, they'll probably know the manual on that thing or how to turn it on. Absolutely. And all they'll certainly be able to tell you all the maintenance that they've had to do on it, how much they paid for it, where they had to get it from, what paperwork they had to submit for it, like all the things that we don't need to know. They know all that stuff.
Plus be able to tell you if that's the issue.
Yeah. Or is it acting up? Yeah. Because that could be one of the things too. So there are some things that we definitely want to ask these caregivers, what happened, like all the things that we would do in our secondary assessment with our patients, we want to be asking our caregivers. But also, especially if there have been experiences like previously that are relevant to what's happening today. So if you have a patient that has difficulty transporting, I have a really good example of this. So one of the calls that I had a couple months ago now, we responded to a patient that was they had difficulty breathing. She was developmentally disabled, physically disabled. I think it was a patient in her mid-30s, underdeveloped arms and legs, underdeveloped respiratory system, cognitive disability, nonverbal. So this patient had a lot going on, but she was still, you could tell like if she was happy or in pain, if she was having trouble breathing, like there were signs to be able to tell like the patient's quality of life. And her parents were the most dedicated and knowledgeable people on her condition you could ever possibly imagine. All the things involved with her care, her whole schedule, her entire past medical history. They knew every single thing about it. They knew all and we're just, I don't want to say just EMTs, but like we don't dive deep into
specific
into
illnesses.
disabilities. Yeah. We don't dive deep into changes that happen within the body and like the organs themselves when somebody has a physical disability.
Right.
So she's telling us all this stuff, and that can be overwhelming, but it's also their way of coping with it. Like they're giving you all the information that they think that you need to know. That caregiver was the best person to give us information on the patient's condition, what she's normally like, how she normally breathes, like what her routine is. Turns out that day she was, she sleeps with a ventilator on, but they take the ventilator off in the morning to help her get exercise. It's really the only exercise that she would get. And when they took the ventilator off that day, her sats dropped and she started becoming hypoxic. So they had to put the ventilator back on. So that was the change for the day. It's like, oh, she was not able to breathe without the ventilator, which may be a progression of her, of her conditions, or it may be something that's acutely happening to her that day. It could be either or. And that's why we're there, right? Okay. So understanding what we're here for, respiratory issues, how do we get this patient to the hospital? Okay, well, at that point, the caregiver was kind of giving us all this information. This ventilator, this is what she uses, is whatever. It uses this. You need to control these things. And while that was super helpful, if we were going to be able to use that ventilator, it was also one of those things of like, okay, we had to look past that and go, what is the best course of action for this patient? Well, we don't know this ventilator.
Right.
We can't use it. It's not certified on our ambulance. So we're going to bag this patient all the way to the hospital. And we're 7 minutes from the hospital. So it's kind of one of those things where all of the information coming from the caregiver was super helpful in some instances. And in some instances, it's like, okay, well, we still need to make decisions as EMS to go, what is the best thing to do for the patient? Right. So you kind of, marry those two things together to form the partnership with the caregivers that are there to kind of get the best care for the patient possible. So I thought that was kind of like a really good instance of if you have that resource available, they can be absolutely invaluable.
Yep.
So yeah, like those are the things that you should be asking. Like the last time she went to the hospital, how did it happen? How did it go? What did they do? What should we avoid? What were the learnings last time? They'll have all that information because they were there.
Right.
That's super important to know, how can we make this smoother?
An aspect of that is what facility is going to be most appropriate to take this person to as well.
Where's their doctor?
Where's their doctor? And in your report to the hospital, especially in an instance where you may need a ventilator, it may be a good idea to say, hey, patient's usually on a vent. We're bagging them right now. Maybe need that respiratory therapist available to us when we get there.
Absolutely.
These are just things we have to think about as we're transporting these folks.
Right.
Yep. So another thing just to call out too is that those caregivers of these disabled patients or patients of special populations, they also in that moment, they may be cool, calm, and collected. They may be, holding it together than you are. Or they may be the opposite. Today may be the day where it is so much work for them most days that the day where things start stacking on top of it and there's something new that they have to deal with, that may be the straw on the camel's back. And it's important for us to recognize that like they have an impossible job that
absolutely,
but we're also there to help them and to calm them and to show them the care and the that we're treating their loved one, the person that they're in charge of caring for, with all the best care that we possibly can to help kind of put them at ease. And that those may be the days that we're called, is because they finally get to a point where there's something they just can't manage,
right?
Because they usually do a heroic job on every other day. So those are things to kind of keep in mind about caregivers, and super important. One other thing just to throw in there, sometimes a patient may be their own caregiver.
Sure thing.
Like while knowledgeable caregivers are invaluable, knowledgeable patients may also exist too. Like
sure.
You're not always going to have patients that are, unable to kind of articulate their condition. Sometimes you will have that, and they will be as good of a resource as a caregiver. So it's just important to know that, like, asking your patients, knowing, like, a patient who is blind and, with people trying to figure out, hey, what's the best way that we can do this for you? He may, hey, last time I stubbed my toe or I broke my foot or something like that, the EMS crew did this. And you go, oh man, that seems like a pretty good idea. We should do that.
Yeah. You use your patient as a resource,
Yeah.
especially if they're able to give it to you.
So the only thing we have to really keep in mind, though, is that being that they are patients, especially patients with like cognitive disabilities, emotional disabilities, things that are that may put them in what we consider to sometimes be a like altered mental status, or maybe not altered for what they are, but like of not alert and oriented. We have to make sure that they are, right. We have to make sure they're alert. If they're kind of giving us information, if they're making decisions, and whether or not they're altered from that normal level of alertness,
right.
And kind of comparing that to, like we said before, like the caregivers giving us information on whether or not this is baseline for them. But we have to give it that little extra level of scrutiny because our patients may be the ones suffering from either some sort of cognitive disability or an altered mental status. And one of the things that we mentioned before, anytime we're dealing with any patient whatsoever, we want to make sure that we're helping them feel involved in the process, and that we're explaining everything that we're doing so that they can feel comfortable with it. They know what's going on, and that they don't feel like things are just happening to them, that we're there to help them.
Well, generally they're part of a population that feels like they don't have any power.
Right.
So if you can empower them, especially to help you through it and give them something to do, it's only going to make the experience better with the patient.
Yeah. So
and talking about caregivers, we mentioned it a bunch of times. There's a bunch of different devices that you may encounter with a patient. And
that's a hell of a segue.
Yeah.
While we're talking about caregivers, let's talk about devices. No, well, I mean, like they are intrinsically linked.
Sure.
And we did kind of talk about conditions that exist for patients. The things that we should keep in mind for all of these patients and all of these situations. But yeah, there are these specific tools that we should be aware of, familiar with. Some of them we even use, like in EMS. But you want to take us through that, Max? All right, cool.
So something that we should be familiar with is something like a CPAP. Something that provides positive pressure to support breathing. It is something that is in our scope of practice, and it's something you may encounter with a patient. Usually it's safe to remove unless the patient needs it acutely. But again, it's something that we can take them off the BiPAP or the CPAP and then put them back on it once we get into the ambulance. Yeah, because it is present.
And one of for a patient with CPAP, usually you may encounter it for they might need it for sleeping. That's typically where they're using a CPAP at home, or they may need it to help with, their congestive heart failure.
Exactly.
Yeah. So those types of things, like we use those. So we may take them off of theirs and put them on ours or something like that.
The main thing is also make sure that you notify the hospital if you have a patient that's using a device, no matter what the device is. Then you have something like a tracheostomy tube. And that's something where you have an airway through the neck and it breathes through a stoma. You need to watch out, especially with these, for obstructions. This is something you may have to either deal with suction if they're having an issue getting air through it.
Because it's just a big hole. It's a big tube that now exists through the trachea, right?
Yeah.
It's from the outside, there could be things that get in there.
And something that goes along with that is a home ventilator. It's a machine that helps breathe for the patient. If it fails, you want to revert to a BVM. You're basically taking the place of the ventilator, like you were talking about with the patient you had.
I've done that. That was the first time I ever had to provide positive pressure ventilation for a patient.
Yep. And something you should check for is a term called DOPE.
Another acronym.
And this stands for displacement if it's not aligned correctly. Obstruction, again, is there something that's in the way? Is it something that has to be suctioned? Pneumothorax or pneumonia with fluid in the lungs, and also is the equipment operating correctly? And that's something where that caregiver can give you that information because they're the ones that are going to be dealing with it on a daily basis.
Yeah, for ventilators too, and I kind of learned this in the field, is, if somebody is on a ventilator, you may not be able to use that. It depends on your local protocols, maybe depends on your medical director, maybe depends on who's in charge of the ambulance that day, on whether or not they feel comfortable with a certain type of ventilator. But if generally speaking, if it's not something that like the ambulance has like certified on there, probably the safe answer is to default away from using it and use something else that is something that you use on a regular basis that you can trust. Because who knows what that ventilator has been
Exactly.
that's the patient's, or if you even have the ability to power it on the ambulance.
But you can revert to the BVM because it's what you're basically taking the place of that ventilator.
Right.
Then you have things like pacemakers.
Yeah, there's a few things that fall into this the cardiac category
Yes.
within specialty medical devices.
Yep. First being like a pacemaker. So this is a device that's implanted under the skin and controls slow heart rhythms. And it's something you really need to be aware of if you wind up having to use an AED or a monitor that has an AED function.
Something you also probably want to ask your patients about, or they may be telling you about it. Like, oh, I have a pacemaker.
Yeah.
Okay. Is it functioning? Does it feel correct? Does it feel like are you feeling any pain around it? Like those are things that we could probably find out about the pacemaker too.
And if you're doing a physical, inspection of the body, generally you're going to see it. They're generally pretty obvious on the skin.
I actually don't know what they look like.
I've encountered a few of them, and it's basically a round cup that's under the skin, and usually you can see it.
Oh, really?
Under the skin.
Yeah. In a lot of instances, you will be able to see it. It may not be the most obvious thing, though. It all is dependent on the size of the patient.
Yeah.
But like I've seen some rather skinny folks that you can tell. It's just a big it's a big lump, and it's usually a good sign that that's a pacemaker.
Right.
But yeah.
Yeah.
Then you have something called the AICD, which is the automated implanted cardiac defibrillator. And this is something that shocks the heart back into a rhythm. It is safe to touch patients during the shock because it's not going to be transmitted to you. Still use AED CPR if patient is arrested. So you're still going to go to the AED.
So it's kind of like a pacemaker, but
it's active defibrillation versus rhythm regulation.
Yeah, so a pacemaker is something that speeds up the heart, right? Like, so if somebody has a slower heart rhythm, the pacemaker kind of, keeps them at the right pace, right? And then, and this is just my understanding of it, because like I'm sure Jonathon be like, "That's too simple, Mike. It's actually like this."
No, that's it. The idea is we're providing, or the device is providing rate control. For this person because their heart is unable to sustain the rate that they need it to be at. So,
and then on the flip side, if the heart's too fast or too irregular, you got the defibrillator, which is for things, if it's fibrillating, like that will help.
Sometimes there are combination units.
Yeah. Oh, they do both. Oh, yeah, that would make sense. Like, but that'd be a rough go. Like a patient's heart who just cannot make up its mind. It's like it's going to be too slow, too fast all the time.
And there's also an external option, which is a vest. It's called a life vest, and it's a wearable defibrillator. And it's an external device that can deliver shocks. I actually know someone that had that placed on them, given to them by the hospital in lieu of them going into surgery for the issue they had with their heart. So it was basically like a holdover, like you wear this vest, and if you have an issue, it just does it externally instead of internally.
Mm-hmm.
That's a lot of times we see that people either waiting on surgery to be scheduled, or maybe they are not in a condition to have surgery immediately.
Right.
They could have other compounding health issues that just don't make them a candidate. So, but yeah, I've seen those a lot. One of the big things, these patients usually know that they've got these devices, but one of the big things I'll caution you, anybody listening against, is be careful with your trauma shears. We don't want to cut through anything.
Yeah. Electrical wires.
That would be bad.
This is a time to be very careful.
And I would assume, I think what we had kind of learned about this is like, you should really only remove it if you have to, because if it's working correctly, you don't need to remove it because it's doing the job that it's supposed to be doing.
Exactly. Like leave it on them, transport them, and let the tool do the job.
Now, I have been on calls where they have been malfunctioning.
Right.
And it's been a while since I've been on a call like that, but I've been on calls where they're malfunctioning and they're inappropriately providing defibrillation.
Oh, right.
So that's an instance where maybe taking it off. But again, you're gonna want to refer to local protocols and medical direction on those calls with those patients.
I think I was actually reading something in the book about those particular devices, the both the AICD and the wearable defibrillator, where in certain situations, if it's near strong electrical fields, like if you're at a like the anti-theft devices at like stores, you should not let them stand in those electrical fields where it's like magnetic, because that could throw the defibrillators haywire and cause improper shocks. I was like, geez, that's odd.
Yeah, at one point, microwave ovens were something to call, like these folks were cautioned against being near. I'm not sure if that's still the case. There may be some folks hanging out. One of the things to talk about, especially with the implanted devices, they have a limited lifespan.
Right.
Oftentimes, they may need to be replaced if they've reached that lifespan. And so when we start to have issues, I've had several patients where we picked them up several times in a short period due to the fact that their pacemaker was failing, right? It was time to get a replacement, and they just had not got that replacement yet. So they started having issues.
Yeah.
Well, I have a friend that has a pacemaker, and they were telling him that basically like in 10 years from placement, he needs to come back in to have it replaced. And also he was doing a lot of electrical work, and they said to him, like, you need to stop doing that. Like, you being exposed and around electrical circuitry it could kill you. So there was like a whole section of his job that he did that he had to stop doing because of it. And that was a recommendation from the doctor once they found out what his occupation was.
Yeah.
And then you have something called a ventricular assistant device, or LVAD, and it's a mechanical pump that assists heart function, and that's in the ventricle of the heart itself.
Yeah. One of the craziest things about this thing, this will always be in my head. You may not have a pulse when you have an LVAD. It's a little pump that pumps blood around for you. It's like it assists your heart, right?
Right.
So the way that it works is like constantly pumping. So
even if you don't have a pulse, you're still moving.
Yeah, those patients don't have a systolic, or I guess they don't have a diastolic blood pressure, because it's literally just a constant flow of blood around the circulatory system. So you have to really look at like their perfusion and their skin tone.
Because this is a question, like, you go for vitals and you don't get any history, and you're like, well, this person's dead.
Well,
but they're not.
There's no pulse, but they're talking to me.
Yeah. So
one of the things I want to mention. So we've got some protocols related to LVADs. There is a call center that's usually associated with that particular device. There's either a card that the person will have or the caregiver will have, or it is actually printed on the device itself. So you may want to look around on the device, and you can call this number 24/7 and hopefully get in contact with somebody that can help you work through any troubleshooting that this person has. Usually these folks, again, they're subject matter experts on the device. It's usually a requirement before they let you go home with something like this, that you've got to show some proficiency in using it, troubleshooting it, that sort of thing. One of the things, like you're talking about evaluating, other signs of perfusion. Hopefully, if you are talking to the person, you're not gonna go initiate CPR on them. You're not gonna get freaked out by that and start CPR, right?
Yeah.
We should not do that. And depending on the device, CPR can cause damage to the device. So we have to be very cautious. They've got some that are more compatible with that now, but you need to. That's why calling that number
is important.
Is important.
It's no different than getting information from the caregiver. Like, that's a resource you should absolutely go to if you don't know what's going on.
Yeah. So, Max, you brought us through some cardiac devices and some of these specialty pieces of equipment. Why don't you let me take us through some tubes and stuff that stick out of the body? Because it kind of like there is kind of a natural delineation there, because there's things that we have to keep in mind sometimes that like assist the way the body works. And then there's some times where it's like, hey, we need to create some holes and put things into the body that are or semi-permanent.
The GI tract may have issues.
Yeah.
And these are things that can help with that.
And, some of these are kind of interesting, like the like feeding tubes are one of the ones that we may encounter, an NG tube. So it basically is a thin, flexible tube that goes down through sometimes the nose or the mouth into the stomach and delivers sometimes like a slurry, like a Slim Fast type of mixture, just to give some nutrition down in the stomach for patients that can't eat or can't swallow, right? Or it could go down into the intestine too. It may bypass the stomach altogether. Important things to know about that is like we shouldn't be messing with them. We shouldn't be removing them. We shouldn't, and especially we shouldn't just replace them if it does fall out. Just hey, luckily, when people are eating, like the digestive system, it doesn't need immediate, immediate food in it. You can usually live a while without food getting in there.
Yeah.
So just leave that out. Tell them what happened at the hospital. They'll probably put that thing back in if it's necessary. But we may want to secure it. Yeah. Put a piece of tape on it so that just to ensure that it doesn't pop out or move. And we definitely want to keep an eye on it for like aspiration risk, because if that thing moves out or gets into an area where it's just kind of like too high up and it may fall, stuff may start coming out of that tube into the airway, and that's not good. So, we definitely want to monitor that and kind of keep that in mind. But there's some other tubes
there are
in the body as well that people put there. I have not experienced any of these, and I'm thankful for it. Urinary catheters. Have you had one of those?
I haven't had one, but my brother-in-law had a really nasty accident, and he woke up in the hospital post-accident, and we jokingly asked him, hey, do you have a catheter? And he said, what's that? And we told him, well, look down and remove your blanket. And he was kind of freaked out about it.
Yeah. So for those unaware, a urinary catheter is a line that goes into the urethra for both men and women. It goes up in through the urethra into the bladder, and then a bulb, like a balloon, inflates so it stays there, so it doesn't fall out, and then it allows urine to come out of the tube, right? And it usually collects in a bag or some sort of device to measure the output. That device is pretty integral to the story of the catheter. Because in EMS, that's if we see somebody with a catheter, usually we're not doing anything with that catheter.
No.
There's nothing in EMS where we usually have to do anything with that. We may have to check it. If somebody's complaining of pain or something like that, we may have to visualize and see things to see if there's infection or misplacement, because we may need to help assess. But the important thing to remember is about that bag where that urine is going. We never want to take that bag and put it above the patient.
Right. We need gravity to do the work.
Because if you think about it, all that thing is doing is allowing gravity to pull urine out of the body and go into the bag. If you put it up above the body, it becomes like an IV bag, and all that stuff starts going back down into the body. No bueno, no good. We do not want that to happen. So we leave that.
Possible risk of infection if we aren't already dealing with a urinary tract infection.
Yep.
So it's one of those things, if you have the option available, don't take that bag and place it up on top of the patient. That is not the proper place for it. Hang it from the bottom of the stretcher, keep it below where the patient is, so that gravity is always working for it.
An additional thing with that, Mike, is be very aware as you're moving these patients of where that tube is and any snag hazards, because you got to think that catheter has a balloon or a bladder inflated, and it's being held into the bladder by that balloon, and we could cause some serious damage if we're not careful. So just if you're listening, be careful when you're dealing with patients that have indwelling catheters. You don't want to pull them out or yank on them or anything like that. That can cause other issues.
But like with the feeding tube, just make sure you're securing that and taking the time to do so it's not some kind of surprise as you're moving the patient.
Yeah, for sure. So urinary catheters, something we should be aware of. Along the same lines, when we have things that need to be expelled from the body and there may be some sort of problem with that, like people put in medical professionals put in catheters because usually a patient is having trouble or they need to monitor the urinary output of that patient. If there's a problem with the way that, bowel movements leave a patient, sometimes they need to have what's called an ostomy bag.
Mm-hmm.
So I have a very good friend of mine who at one point in life in his 20s experienced diverticulitis, which is super weird for somebody of that age. And essentially diverticulitis is like a tear in the colon.
Mm-hmm.
And he had a massive infection and they had to provide emergency surgery where they basically removed that section of his colon. And when they removed the colon, you have to let the poop go somewhere. So he went into the hospital almost dying and came out with a cool bag that like suction cup to the front of his body with a new hole. And that hole comes out from the large intestine, and it basically, it allows fecal matter to leave the body through a new hole, a stoma, and it collects in the bag. And then, they get used to it. It's part of their daily life to kind of deal with having that bag there. Usually it's on the front of their body. And that can be removed, or it has to be removed, emptied, or replaced. And it's just another way of kind of collecting and dealing with bowel movements, right? So that may be something that we have to deal with. And it's important to know about it. It's super important to not put any pressure on it, pull on it, tear it. Like that would be a bad day.
Yeah. So
being aware of those things. And we also, as EMTs and paramedics, we should be looking at those things to monitor could that be a problem? Is there any infection happening around there? Is that causing a problem? We could be the ones to help kind of diagnose that. And we should really just be making sure that, it's not leaking or causing any additional issues. But ostomy bags are one of those things that we have to kind of keep in mind too. And then last but not least, we have a couple of other tubes, more tubes. There's a bunch of tubes that people get inserted into their bodies. So one of which is central lines. We talked about this kind of briefly with the dialysis access.
We did.
With fistulas, that's what usually you use for dialysis, but there may be something called a central line or a peripherally inserted central catheter. Again, it's very similar. It's something that gets placed within the body for people that need regular access for IV stuff, right?
We had a patient elderly lady who had really, really bad veins. And she was going in and out of the hospital, in and out of treatment. So they put in a central line. That way they would have access because they were having such a hard time establishing IVs.
Yeah. And one thing here, and from our standpoint as basic, providers, we probably would not be fall into this category, but I assume this is more in your realm, Jonathon. The kind of rule of thumb is you do not use that central line unless you're trained to use it.
Yeah.
Yeah.
Generally, it's not something we would use on the ALS side of the house. Now, there are some protocols that do allow. Again, there would be specialized training,
right.
But as a general rule, protocols kind of shy away from that.
Right.
Now, you may be in an area where they do allow access to that, but there are significant risk of infections, and there's a whole procedure and kit for accessing that. And the back of an ambulance is not really the place we want to do that.
Yeah. So, central lines are a thing. We want to be aware of those. We want to avoid dislodging any central lines or contaminating them. That's the big thing to keep aware of. Just like we would with the fistula, we try not to impart anything on it to dislodge it, to cause any pressure on it, or disrupt what's already there. And then the last thing to kind of keep in mind is this is a
hell of a word.
Mouthful of a word. ventriculoperitoneal shunt.
Nice.
A VP shunt. I have a friend with one of these. He's had it since he was a little kid. He had hydrocephalus, I believe it's called. So too much liquid in the cranial cavity, and it drains fluid from the brain to reduce pressure. So it's usually not on the outside of the body. You don't see it, but it drains fluid from the brain down into the peritoneal cavity, and it's there to help kind of relieve pressure.
Right.
So they may tell you about it. Really, if somebody does have that, you want to see if you can, you want to be more aware of signs of intracranial pressure. So that Cushing's triad, irregular breathing, decreased heart rate, and decreased blood pressure, increased blood pressure, because those things are indicators of intracranial pressure. And same thing we do with every patient. We'd probably want to treat any life threats and then transport them, because that's not something that we can really help with. So a lot of things. I know we say this every time. There's a lot of topics in all of these subjects that we go through, but really, I think the constant themes in a lot of these things is, providing good patient care, treating patients as individuals, and being there for them and listening. That. Those are all skills that we do with in every topic, right? So we've gone through a bunch here in terms of conditions and devices and things for particular patients, and then the last section that this chapter really kind of got into is something that we touched briefly on last week's episode for obstetrics and gynecology, but it went a little bit deeper this week in terms of patients that may be victims of abuse and neglect.
Right.
So that's the last thing we'll get into in this topic. Jonathon, you want to take this one?
Sure. And so if you listen to our last episode when we talked about those gynecological emergencies and things like that, we did talk about being mandated reporters. And so I think that's a good place for us to start.
Oh, sure.
In relation to this. So basically it comes down to, for children, so anybody under the age of 18, for the elderly, and your individual state is going to typically give you a guideline. I believe it's anybody over 65 is where we start to get into that. But your state laws may be a little bit different depending on where you're listening at. And then anybody that maybe we've talked about with those intellectual or cognitive disabilities, those folks would fall into the realm of being mandated reports. Now, when we talk about typical adults, we're not necessarily mandated reporters for any sort of abuse or neglect. And the idea is that is protected information under HIPAA, and we don't want to violate that for that typical adult. But getting into those special categories, right? We talk about child abuse and neglect. And so if we talk about abuse is a direct thing that is being done to that child to cause harm.
Right.
And there's a couple things that, we need to be aware of. So any sort of inconsistent history that you're getting from maybe a parent or a guardian in relation to the nature of this injury that 911 was called for. And that could be, big things we want to look out for are bruising, burns, any fractures that may have unusual patterns, but that might not be something that's apparent. Kids are accident prone.
Right.
But if you see what looks like to be a handprint somewhere, or like on the forearm where a kid may be grabbed, or what looks like cigarette burns or something to that.
I was just going to say
that effect.
Cigarette burns are probably one of those ones where it's very rare that children would get small circular burns, especially And the one that something else for this category too is like a varying pattern of older and newer injuries
Yes.
that look the similar to each other. So it shows like, oh, this has been happening and is still happening. That's one of the big ones too.
Yep.
And so one of the things that we want to be careful of, we don't want to make it, we want to be historians. We want to gather the story. And then if we suspect it may not be an appropriate time, it may not be safe to do so. We don't want to make any accusations. We just want to gather the information and then share that with the appropriate resources, whether that's Department of Social Services or Child Protective Services or Adult Protective Services.
Or the police.
Yep.
Or the police. Yep. And typically those are going to be calls that are done in tandem. You're gonna call the local law enforcement agency to you or to the call. And then you're also going to call the local social services and let them know what's going on, as well as letting the staff in the ED know what you suspect.
Right.
That's going to be a thing. And so that's with abuse, but neglect. Let's talk about that, because this could be more of an indirect thing.
Right.
Right. So
it's
with the abuse, we're talking about
not doing something.
Exactly.
Yeah, we're talking about injuries, but with neglect, we're talking about, again, not doing certain things. And so this could be like children that are not taken care of with their hygiene, right? They look like they haven't bathed in a long time. This could be malnutrition and signs of that, with them being emaciated or, other things like
vitamin
their hair and their
deficiencies,
nails and things like that,
jaundice,
not being in good condition.
Yeah.
This could also be something like a lack of supervision, right? It has mom or dad or the caregiver, are they not paying attention, and the kids, playing in an inappropriate place or isn't being, looked after, right? A 3-year-old should hopefully not be wandering in the streets.
Right.
Yeah.
And that could be a sign of neglect, right? Especially with other factors, when you finally get in touch with mom and dad and start talking to them, and and the other aspects of that are going to be, again, we've talked a little bit about the physical abuse, but then there can also be the potential for sexual abuse as well, which is that's a whole thing that.
And it doesn't necessarily just have to be children.
Nope.
It doesn't. It doesn't. Right. It doesn't. Right. So we can, all the things that we talk about with children as far as abuse and neglect are concerned, they also can apply to elders, right? Our geriatric population. This is something that, man, it's usually not reported on. And in fact, one of the likely sources of this abuse is potentially caregivers, whether that be caregivers in the home or caregivers in a facility. Again, we're not here to make accusations. We're here to make observations and then report what we suspect based on those observations.
Right.
With older folks, it's a little bit of a different presentation. We may see signs of dehydration, especially if they're bed bound, right? They rely on somebody to get them nutrition. So they may be dehydrated, they may be malnourished. We may see pressure sores. As we talked a little bit earlier in the episode, we talked about folks who have skin breakdown due to sitting in feces or urine for too long. That can be an issue. And in addition, just generalized poor living conditions.
Right.
Now, that alone does not necessarily mean that neglect or abuse is going on. But if we have a lot of other signs, it can be a difficult thing because, with poverty being prevalent, one thing you can encounter is the living conditions are maybe not a way you or I or any of our listeners may want to live, but this may be the means that this person has available to them, and that affects giving care. So that's a tough one too, and that may be a conversation of just seeing about getting additional resources, but in conjunction with the other things I mentioned, that might be a sign of abuse.
Right.
And so we may want to talk to our adult protective services or maybe even our local law enforcement agencies. And we definitely want to report our findings to the emergency department.
And I'll just throw in here too that, like, you know, this is also, you know, neglect is one thing, like, you know, those patients kind of not getting the care that they need, but also just as we've seen, unfortunately, this is the reality, like the elderly population with like caregivers that have regular access to them, sometimes that can be an abusive relationship as well, like physically abusive, sexually abusive. So all the same things that we look for in terms of signs of injuries, you know, along with the signs of neglect, we should be keeping an eye out on those too.
Right. And to the idea of if we suspect sexual abuse or any kind of abuse, like we talked about in our last episode, this is a time where we want to have a chaperone or have our partner when we're doing any sort of physical examination, especially of reproductive organs. And there's a couple indicators or, you know, signs that somebody might have something going on related to sexual abuse. And that may be genital injuries, history of STI or sexually transmitted infections, and then behavioral changes. You know, somebody may feel very, very uncomfortable or may act out. A patient may act out if you're trying to provide an assessment and maybe you get a little too close to them. They may have a behavioral change. They may withdraw and be reluctant to talk to you. It's a good time to, if you suspect this, it's a good time to kind of separate caregivers and the patient and see if they will talk to you. They may not be willing to talk to you. And so this is a time where we want to be advocates and, again, provide those findings to the appropriate resources, whether it's adult protective services, child protective services, local police, or our physicians in the ED.
One thing in that category too, just as a red flag that everyone should always be aware of, just because I've done like the child abuse protection training, especially with the scouts. The scouts do a great job of making sure everyone has to go through this type of stuff. So one of the ones that is always a huge thing to look out for is like hypersexualization in children. Like if they are acting in a way that is like not matching their developmental ability, that's a huge one that you should definitely look out for. Like if they seem to be coming on to you, like if they're acting in a sexual manner towards an adult, that can be a huge indicator that kid has been abused.
It's learned behavior, and you're not going to learn that behavior generally from a child.
So there's a lot of things to look out for, like the emotional side, the behavioral changes, withdrawal, like, you know, abuse, like, you know, injury signs, but all of those things need to be things that we're aware, like we pay close attention to when we think, like, you know, if the hackles start or the hairs start raising in the back of your head, like start asking yourself questions, like, you know, don't let it slide, you know?
And again, a big thing, we're purely reporting on what we observe. Right. And the other aspect, right, it may not be somebody in the home or that is a caregiver. It could be somebody else. Now, it could be a caregiver, but I don't want anybody that's a listener to immediately think that points the finger directly at the caregiver, because it could be somebody else in the picture that's not there or present. I know that the one instance of child abuse, or one of the instances of child abuse that I have had in my career responding to, was a little girl, and she was at the babysitter's, and the babysitter was the one, which was a caregiver, but it was not a parent.
Right.
And so with this kid, and I think I've told this story on the podcast, but she had raccoon's eyes and battle sign behind her ears and had an altered mental status, and it was very, very significant signs of abuse. And she ended up having a seizure as soon as we got her to the hospital. It's one of the few times in my career that like I was dialed in and we were getting her to the hospital as quickly as possible with due regard. I mean, it's like I was at the hospital very, very quickly. But our next call after we, transitioned or transferred care was to local law enforcement.
Yeah.
So, anyway, so we talked about those special populations, but it also could apply to people who maybe are, they are adults, right, and they don't have any of these special considerations that we've talked about through the rest of the podcast.
It could be, sorry to jump in, Jonathan, but like, I like based off of what I know is in this section, to me, it kind of breaks down into two different categories. There's the what's happened in the past, like, oh, okay, so the abuse, the neglect, the things that we're looking out for that could lead to injuries or things that we're noticing like in the present, like that have happened before. And then it seems like, there's also another category for things that are happening now or currently, in the present, like, and that's where we start getting into like, I think what they called it, intimate partner violence or, domestic violence.
Yeah.
And those things that are like, how are we, and that may have an element of abuse to it, like, in past abuse, a history of abuse, or it might just be something that's happening the first time, we're seeing fresh.
And these are the tough ones because these are otherwise, healthy adults. They've called 911 for some reason, but these are otherwise healthy adults who are capable of making decisions, but maybe due to being afraid, right? Maybe they've been threatened with physical violence, or they've been emotionally abused and told that they're worthless and different things like that. Maybe even they're being financially abused. We do see that with the elder population as well. And these can be tough because this is not a category where we're a mandated reporter. This person has to make a decision if they want to speak about it and get some help and get some resources for it of their own volition. The best thing you can do in these instances is say, hey, there are resources available. There are ways we can make sure you're safe. And if you'd like to go down that path, we would love to help you. Yeah. That's the best thing. These folks often just need, they need some encouragement and they need some emotional support, and we can be a part of starting that process for them.
Also, just to make a note here, I think it's none of us want to experience this, but there may be the situation that arises when we are in the middle of that type of situation that exists.
Yes.
So like we respond to a trauma call or something that does not present as a domestic disturbance, right? We get to a location and there's maybe not an immediate indicator that, the head lack that this patient is showing was from a violent altercation. And then all of a sudden we're in there helping that patient, and then tensions start rising and voices start getting raised, and you did the thing, and then those two people start going at it again. There's always that chance of happening. So it's just to say that like one of those things that we should always be aware of it. While we're always doing the best for our patients that we possibly can, the first person that we need to be worried about is our own safety. So that's kind of like one of the things that we have to be aware of.
Yes.
In that kind of, intimate partner violence, domestic violence, we might always stumble into that thing. In which case, by the way, if you're in the middle of seeing something, you're not just a reporter anymore. You're now a witness. So that is a different thing entirely, and you should definitely be working with your police partners on that, because if you're seeing something like that, you should be calling for help and letting them know everything that you're seeing, because that's a different situation.
And a strategy, like if you've walked into a situation like that, I've been very fortunate and have been able to avoid a lot of those situations. But if you start to notice things and your sixth sense is kicking off and you're like, hey, something's not right here, it might be appropriate to say, hey, we got to go get some equipment out of the ambulance. We'll be right back.
Yep.
And then to call your law enforcement
Yeah.
partners and let them make sure the scene is safe, to keep you safe, hopefully to keep the patient safe. They had an instance here where I provide care where a crew answered a call for an unresponsive male, and they started looking around and noticed that the male was unresponsive, very obviously dead. There's a pool of blood. They noticed some shell casings, and they're like, okay, we gotta go check on some things. We'll be right back. Well, it ended up being that the son had murdered his father and then called 911.
Jeez.
And yeah, so you can walk into situations where domestic violence has occurred, and potentially even a situation like this. But the big thing in that instance is your safety, and so you need to extricate yourself from it.
Yep.
Yeah. So lots to consider in the kind of abuse and neglect space, things of your, like, you know, safety for yourself, safety for patients, you know, like this is a really interesting topic because, like, when you go through school, they kind of introduce you to this idea of mandated reporting, but there are stipulations to it on who you are mandated for and who you're responsible for reporting for. But I think the important thing to remember is, you know, especially, and I think this is why they put it in the same chapter as, you know, patients with specialty needs, is like, we are an advocate and somebody that needs to be looking out for patients that are vulnerable.
Yep.
Right. And that's really the story here, is like, elderly patients are vulnerable, children are vulnerable. And patients with special needs, cognitive disabilities, all these other things, they're vulnerable. So depending on the locale, depending on the protocols and laws in your area, some of those patients may fall into that category as well. So we may wind up you may be a mandatory reporter in that situation. But the last thing in this kind of category, though, is one that's it's a little bit amalgamous. Like, you can't really put your finger on it like super well, because it may not be something that is apparent. But the last thing they kind of touched on in here, which is odd because it may not even be something that shows as injury, like something that we're responding to as you know, EMS professionals, because we may have suspicions of human trafficking, which is a huge problem nowadays. And, you know, if you're not aware, this is when patients are controlled and they may be fearful and they unable to speak freely. They may have scripted answers. They may have a handler, somebody who's telling them what to say and do. Again, if anybody,
I was just about to say the same thing. We've said it a bunch of times, but in the show The Pit, there is a really good example of what seems like a very innocuous thing that is, well, it doesn't seem like a big deal at first, but it so shows all those signs of human trafficking.
Yeah, season 1 of The Pit. I love relying on The Pit because they just articulate it so well. And they show these exact things. So in season 1 of The Pit, there is a female who comes in, I believe with an STI, and they interview her. She has her, like, the woman who is her boss. There, who's super controlling, and it turns out she lives with the boss, and all these other things that are all of which are signs and kind of red flags for human trafficking, and like this person being in a controlled relationship. Those are the types of things you should look out for. And again, it's kind of, this is the disappointing part, because you can't do anything really for a patient who is alert and oriented, and an adult that doesn't want you to do anything for them. But you can try and help them. You can give them the resource, like, you know, access to resources that could be available. You can convince them or try to at least convey to them that, hey, there are people looking out for you, and we're here when you need us, and that type of stuff. But like, those are things that can be, you know, the red flags. So like other things like lack of ID, you know, and those signs of abuse and neglect, because those are those go hand in hand with human trafficking, which usually, like, victims get forced into like sex slavery and all these absolutely horrendous things. But it's important to kind of do what you can, but also to not put yourself at risk, because usually if they do have a handler there, if there is somebody involved that you may think be the one trafficking them, you don't want to expose yourself and put yourself at risk to somebody, because usually there is more dangerous elements and like organized crime elements that are involved in trafficking. So you don't want to necessarily expose yourself to somebody thinking that what's up or you're trying to expose them, because that could put you at risk. So it's a delicate balance, and sometimes we may be confronted with those things in EMS. If it's not a clear black and white answer.
Right. Exactly.
A strategy for ensuring safety and maybe getting this person to a more safe environment and getting yourselves to a safe environment. Again, like we talked about, maybe you need to immediately extricate if there's danger. But if you've got this controlling person not allowing the patient to speak and sort of things, is to emphasize how important it is that they be evaluated at the hospital.
Right.
The more time we can get them there, the better off that they're going to be.
If you can get them to the hospital, then you can maybe start to get some resources and kind of get a bigger picture of what's going on. So if you can just, again, emphasize, yes, I think this patient absolutely needs to be seen at the hospital. And then if you can, not allowing that controlling person to ride with you in the ambulance.
Yeah. If at all possible.
If at all possible. And even if you have to, even separating them and making them sit up front, which most of the time for any adult, we usually, if we allow somebody to ride, they have to sit up front.
Right.
So
that brings us through the chapter of patients with specialty needs, specialty populations. There's a lot to consider, I think, and just some general things that, some themes that we've talked about a bunch. Caregivers are key to success.
100%.
Treating patients as individuals and making sure that we're adjusting to their, what suits them best when we can, I think is important.
Yeah, absolutely.
But why don't we bring it back around to our, one of our regular segments, and this week talking about a tool that really anybody that we bring into the ambulance is going to experience.
Well, and how I missed this as we went through all of the tools that we use on a regular basis, every single time we go, almost every single time we go into a house or we deal with a patient, because it deals with the transport of the patient, is the collapsible stretcher.
Yeah. So this week's tool of the trade is
the stretcher.
The stretcher.
The thing that you use to get the patient from the house to the ambulance, from the ambulance to the ER, to the bed, to the care. And generally, they have 4 wheels that move independently, so it can spin in circles if it needs to. A lot of them have an electric or hydraulic system that can raise and lower without actually having to lift them. Some of the old style ones still do have a manual release to them. They also have a series of buckles so you can secure the patient in place, as well as guardrails on the side that can keep them stable in place, and also allows you to do things like we talked about last week. If you had a pregnant patient that was having issues, being able to lay them on the side and being able to support the baby.
And one thing just to so it's not undersaid, because we're so far into this now that we think a stretcher is like we know what a stretcher is, and we know exactly what it is. But for anybody out there who is maybe listening to this episode for the first time, and if you are, welcome. You picked a hell of an episode.
You did.
The stretcher, what we refer to as the stretcher, is that removable bed that's on the back of the ambulance, right? And usually there is a securement device in the ambulance, whether it's a powered lift stretcher, which is
some ambulances have, that loveliness, and most do not.
Like a bougie service, like my hometown service. Amazing to have a powered lift on the gurney, or it's something that you have to manually hold as it comes out, and then the legs will extend down to then support the weight. That's what we're talking about, is the ability for a patient to lay on a surface and that surface to kind of roll and be locked into the ambulance, and that a bed with like cleanable surfaces that will secure them laying down in a supine semi-Fowler
position,
or Fowler, or even, maybe Trendelenburg position if you flip them around, or if the gurney has the ability to lift different areas. But it's a skeletonized, rolling bed.
Exactly.
That's essentially what we're talking about. A rolling cot, if you will, that can lift and lower patients into the ambulance.
I mean, it is a tool that every EMT is going to use.
And even though I've used it a bunch of times, I don't know why I still hit the wrong button every time it comes out of the ambulance. You know what? Let us know if you also sometimes hit the wrong button, because I swear every time I take that thing out, I hit the less button, the minus button when it comes out, and then they make fun of me for hitting the wrong button. Yeah. I'm like, less down is less. No, you have to hit the plus button because it makes the legs longer.
Yes, exactly.
I know people have been doing this for 40 years and they still mess it up.
My brain doesn't work. My brain doesn't work the way that thing does.
And some stretchers have some interesting abilities. Some of them actually weigh the patient.
Oh yeah.
That way for medications and things, you can get an accurate count. Also, a lot of stretchers now have a built-in spot for O2, for a tank, so that you don't have to carry in a separate O2 bag. That way you can put them on oxygen, whether it's a rebreather or nasal cannula,
or CPAP.
But the main thing about the stretcher is an ability to secure your patient, whether it is movement from the house to the ambulance or in the ambulance en route to the hospital. Some history behind them.
Oh wait, I want to talk about some other features that I learned in the field about stretchers. One, you can put things places, like sometimes they will have the ability to stow things behind the upper portion. So like on some ambulances, you will find really important things in those spots, like emesis bags.
Yes. C-collars,
nasal
cannulas. There's often things hidden in hidey holes behind the stretcher. So just know what's there, because let me tell you, when you want a emesis bag, you want one now.
Yeah. If you don't know what an emesis bag is if someone's vomiting.
Yeah, it's a little vomit bag.
Yeah. Not to mention our service that I volunteer for, the key to be able to get into the ER is present behind all that stuff attached to the back of the stretcher.
Yeah. Yeah, it's there. Usually it will have a bed area, like a little trampoline by the head area that holds some stuff. I guarantee you, if you're looking for like an extra sheet or blanket, it's usually there, or the clipboard with the important patient information on it. Usually that's where that goes. But I think one of the coolest things about stretchers that you can put more than one person on them for certain purposes. So one of the things that I did not realize was they were capable of doing, obviously you could, like, if you need to do CPR, you can put somebody on top of a gurney or on top of a stretcher to do CPR while they're on their knees straddling a patient. But you could also do what's called riding the rails.
Yes.
Where if you're performing CPR on somebody, you need to do it while you're going into the hospital. You could just hop right on the rails on the side, put your feet on there, and then the other people can push you along while you're doing chest compressions.
And one key thing that I have learned and been yelled at for a million times: stretchers don't move sideways.
No,
you don't ever move a stretcher sideways.
Yeah, don't do that. Yeah, because they're tippy.
Yeah.
Like you don't ever want to, like, especially on a rough surface, they turn sideways really well for like moving up against a bed or for rotating, but you always have to move them in a straight line from front to feet. Like in that linear fashion.
And one of the nice things about stretchers being able to reduce in height is you're able to get patients that maybe can't climb up onto it, or if you're transferring a patient from a chair to the stretcher or from a bed to a stretcher. So you're able to adjust the height so it's easier to get the patient onto the stretcher to get them moving.
You will use the stretcher a bunch in this world.
Almost every call.
It's probably the most used tool.
Oh, and by the way, You know what else a stretcher does really well is carries all the stuff you need for when you go in on a call.
That's a good point.
It's an empty space. Fill it with the stuff you need instead of putting it on your back or your shoulder and carrying it in.
Yeah, like you should bring all the stuff into the calls
always.
instead of leaving them in the ambulance. Just
So
Oxygen bag, suction,
all the stuff, everything. Just bring it.
yeah,
cardiac monitor,
yeah. You should probably bring that with you every
drug
time.
kit.
Yeah. It's almost like if you stage that by the front door, it's a shorter walk to get what you need.
Yeah.
It's crazy. So some history. So the earliest known stretcher design appeared in 1380 French manuscript depicting a wicker basket with a wooden frame used to carry a wounded knight. And for centuries, the standard remained a simple canvas sheet suspended between two rigid wooden poles, kind of like a Reeve stretcher.
Yeah, the stretcher.
That was like the stretcher. In the Civil War, inventors patented various folding models for the U.S. Ambulance Corps to balance strength and portability, which is kind of what we use now, just a more updated version. One notable example was the Coolidge stretcher bed, which featured hinged wooden legs that could lock in place to serve as a field hospital bed, which sounds really close to just a wooden version of what we use now.
Possibly, yeah. I mean, like, I'm sure there are a ton of differences, but I think the big one is, at some point they started adding wheels.
Yes.
And that's...
And in 1900 to 1940, the wheel cots became kind of the standard. There was one called the Baumgardner cot in 1910, and it pioneered the 4 swivel wheel stretcher, later adding an adjustable backrest and a foot drop that allowed to convert to a chair, which is very similar to what we use now. And it continues to evolve. Funeral homes. In the mid-20th century, ambulances were often operated by them, and consequently, many early stretchers were modified mortuary cots designed to fit into hearses. That's not morbid at all. But the main thing was the Furno Revolution from the 1950s to the 1970s, which is a recurring theme in tools of the trade. This is where basically things got standardized. Modern EMS, as we know it, began with innovations from Richard Furno and the Furno Manufacturing Company, which used lightweight materials, elevated and collapsing cots as well. And then now modern ones using powered systems like the Stryker that we use in our services. They use hydraulics, as well as the bougie services that have automatic loading and unloading, as well as the ability to electronically raise and lower.
Yeah, we're a Stryker.
Yeah.
Yeah. Now, here's where we're going to be controversial again. You let us know. Do you like red cots or do you like yellow cots?
If you said red, you're wrong.
Yeah.
Just saying.
Sorry,
Yellow
Furno.
cots all the way.
Yeah,
They've
Stryker
got
is
red on them though.
Well,
Yeah.
but yeah, only on the things that are supposed to be squeezed and
that's the other thing too. If you see something red that's not coming out of a patient, but if you see something red that's a part of the cot, it does something. You should learn what that does before you get onto a call. I speak from personal experience because I knew a couple of the red things, and then someone asked me to do something with the cot. I'm like, and his description was just push the red thing.
Yeah, I do recognize that usually that is the answer. However, it is less useful than understanding what that red thing does for what part of it. Because you know how stair chairs have a lot of red things on them too, but you need to know what that red thing does to make sure that it's doing the right thing. So all you people with your color nonsense, just slow down.
Because some people can't tell what the red thing is.
Some of us don't emphasize color in our brains. Okay. All right. Chill.
So it's like everything else. Like you want to know what you're dealing with in your ambulance. So here's an idea. When you're not on call, instead of watching Netflix, go into the bay, unload the cot, and mess around with it so you know what all the things do.
Maybe let them know that you're taking the cot out of the ambulance and
Maybe.
like make sure that it can go back in pretty quickly.
Maybe.
Have somebody show you.
Yeah.
Ask somebody to show you. Hey, will you show me all the features of this stretcher?
Just
maybe listen to Mike and Jonathon, because that is not what I did, and it potentially could have caused problems. But
don't ever do anything with the ambulance that puts it in a spot that you can't put it back together in about 5 seconds. Like if you want to look in a pocket, great. Open that pocket and then close it before you go to the next pocket. Like,
well, yeah.
Like that is we like if you want to look at the stretcher, look at it, play with it, but don't take it out of the ambulance.
I took it out of the ambulance.
Like that's fine, but just like as long as it goes right back in. Like, it's like I'm practicing unloading and loading it, it doesn't need to be out of the ambulance. You need to make sure that thing's ready to go.
Yes. But yeah, so it is a tool you will use on almost every call, even if it's just to carry all your stuff. Get familiar with it.
Cool. So I think that's a long-awaited tool of the trade.
Long overlooked tool. That's for sure.
But there's still so many. I guarantee you, Max. If
Oh,
you looked,
without a doubt.
I made a list of every single item on the ambulances at my hometown service. We're not even
close.
We're not even like 1/20th of the way through the list. Like there's everything that you could possibly imagine on an ambulance. We've taken a lot of the big ones, but there's so many left. So don't count yourself short. Like there's a lot to go through, and there's a lot of things that we don't. But yeah, that's one of the big ones, and we've got plenty more to come.
And Stryker, if you'd like to sponsor us,
like if anybody has a connected Stryker, we're willing.
We don't have anything to put it in yet, but. We'll figure it out.
Stryker has other stuff.
Yeah, right.
If you want us to carry around a Stryker cardiac monitor, we'll do that.
Send us a Life Pack 35.
No, Life Pack 15.
I'm just kidding.
The Life Pack 15 is superior to the Life Pack 35, in my opinion.
Anything that is sent that has Life Pack associated with it.
Yeah, I'll take a Life Pack 10.
Yeah,
I don't
2, whatever. Yeah,
but no, let us know which Life Pack you like, because that's a hotly debated topic in EMS.
It is indeed.
All right, so maybe we'll get to that at some point in Tools of the Trade. If we ever get our hands on it, we can borrow a cardiac monitor.
Well, it just gives us a valid reason to get an ambulance.
I don't think those two things are related, but okay.
I say it is. Just saying.
All right, so that brings us through our Tools of the Trade.
Indeed,
and
it does.
We've gone pretty long in this episode, but why don't we wrap things up, Jonathan? Get through our 3 questions, because we cannot let ourselves slip.
Nope.
We need to make sure that we are studying.
Yes.
All right. Here's your student test prep for the week. And this particular episode, I'm going to give you guys one of the newer style questions that is reflective of what's on the NREMT test.
I hate these. I hate these.
Yeah, so it's not your standard question where you just pick the one that's most correct. They have transitioned into some questions where you're having to put things in the proper order of operation.
Yeah, they had some of these in our test.
They did indeed.
So here is a sample of that kind of question. All right. Are you guys ready?
Sure.
All right. You are assessing a 10-year-old child who was struck by a car. He's lying supine, not moving, with heavy external bleeding from a leg wound. What is the correct sequence of priorities combining life threat identification, vital signs, and decision making? And you need to place the following in the correct order. So what is the most appropriate thing in order of appropriateness? Okay, so I'm just going to read off the answers. The first answer is going to be determine transport priority, rapid transport versus stay on scene, assessing airway patency and opening the airway if needed, rapidly assessing pulse, respirations, and perfusion indicators, and controlling the external bleeding immediately.
Want me to take this one?
Yeah, you go for it.
Okay. So looking at the answers and going X, A, B, C, order of importance, I would go number 4 first, control the external bleeding immediately.
Okay.
Number 2, assess airway patency and opening the airway if needed. Then 3, rapidly assessing pulse, respirations, perfusion, and perfusion indicators. And then 4, last one would be determine transport priority.
Okay. I would do the same.
Okay. And so the line of thinking is you followed your XABCs and applied those answers in the appropriate order.
Yes, sir.
Okay. That is correct.
Yay!
Right? So we want to control that bleeding first because it's life-threatening. You need to assess the airway and open it if needed. Then we're going to rapidly assess for all the different things, pulse, respirations, and perfusion. And then we can make the determination on transport. So you guys got it correct.
Sweet.
Follow the XABCs.
Exactly. Because these questions are it's so easy to mess you up. Those style questions with the order.
Oh, yeah. There's some that are way harder than
it's
that.
Crazy.
I'm glad that we were able to get one of those questions in, and hopefully we'll get some more of those types of questions.
There's some that really try to test you. Like if you're trying to figure out the like, some real nuances between do I determine transport priority first, or do I figure out, or do I call for, ALS? Like in the real world, those things are going to happen fluidly and you're going to make the decision as you go, but they want a specific answer of like exactly how it's listed in the NREMT. So like there's sometimes when it's really not that apparent, but that one's nice because you could just go by the primary assessment.
Yep.
All right. Question 2. You are part of the first arriving EMS unit at a mass casualty incident, an MCI. The scene is safe, and you begin rapid triage using the simple triage and rapid treatment, or START system. A patient is found lying on the ground and is not breathing. Which action is appropriate at this point in the triage process? Answer 1, open the airway once to assess for spontaneous breathing. Answer 2, assess radial pulse and capillary refill. Answer 3, initiate cardiopulmonary resuscitation if the patient remains apneic. Answer 4, apply a blanket to prevent hypothermia.
I could take this one if you'd like.
Go for it.
So, if this was a normal situation, like, it was not an MCI, the answer would be different because we have different priorities, especially if it's a single patient. But we have to assume there's multiple patients. There's a reason we're triaging. So if that's the case, a patient that is unresponsive has, and is not breathing, essentially we gave them the best chance that can help them, and then we have to move on. Like that's essentially the line of thinking. So, some of these ones here, assessing radial pulse and capillary refill time, while that seems like it's quick, it's not the best bang for the buck in helping somebody. And then you're still taking a lot of time in assessment there. Initiate cardiopulmonary resuscitation if the patient remains apneic. We're not spending time doing CPR if we're a single provider and we have to go help other people. Unfortunately, that's just the case. And applying a blanket to prevent hypothermia, that is so far down on the list of priorities right now because we're trying to take care of life threats. While hypothermia is a life threat, I will say that, but it's not one of the immediate interventions that we would normally do. So the only one that stands out to me is like, hey, what can we do to help affect this patient the best? We open the airway once and we assess for spontaneous breathing. And if nothing happens, they get a black tag and we go on to the next person.
Yep.
That is the correct answer.
Awesome. Yep. 2 for 2.
Woo-hoo. Excellent. All right. Last question. A 20-year-old patient with a history of asthma is experiencing shortness of breath and wheezing. The patient is alert, able to follow commands, and request help using their prescribed meter-dosed inhaler containing albuterol. Which mechanism best explains how albuterol improves the patient's breathing? Answer 1, reduction of airway inflammation by inhibiting histamine release. Answer 2, decreased mucus production by blocking mucocarcinic receptors. Answer 3, improvements of gas exchange by increasing alveolar blood flow. Answer 4, stimulation of beta-2 receptors causing relaxation of bronchial smooth muscles.
I've got 2.
This one's tough.
It is. I've got 2 that I think are possible.
All right. So let's look at it. History of asthma, experiencing shortness of breath and wheezing. The patient is alert, able to follow commands, requests help with prescribed metered dose inhaler containing albuterol.
Right.
All right. So really what it's asking us is what is the mechanism of action for albuterol?
Yes.
Which mechanism best explains how albuterol improves the patient's breathing? Okay. So this asks some really specific questions about pathways, things that we don't necessarily dive very deep into, but what do we know that albuterol is?
It's a bronchodilator.
It's a bronchodilator.
Exactly.
Cool. So which things on here seem to be in line with the idea of being a bronchodilator? So reduction of airway inflammation with inhibiting histamine release.
No.
Well, reduction of inflammation maybe that can dilate. I don't know. We'll put that one in a maybe category, but I think there might be a better one for it.
Mm-hmm.
Decreased mucus production by blocking muscarinic receptors. Well, that's not saying opening anything.
Exactly.
It's not a dilator, so get rid of that one. Improvement of gas exchange by increasing alveolar blood flow. That
was my like number 2.
They like to throw those in there because like improvement of gas exchange doesn't sound like a bronchodilator. And they say increasing alveolar blood flow. You'd be like, oh, well, it's making it's dilating the blood vessels, but
right.
We're not a blood vessel dilator. We're talking about bronchodilator.
Exactly.
So that's trying to let's throw that one out. And then stimulation of beta 2 receptors causing relaxation of bronchial smooth muscle. So relaxation of bronchial smooth muscle sounds like it could be a bronchodilator. So to me, it kind of lands between, inflammation by inhibiting histamine, the reduction of airway inflammation by inhibiting histamine release or stimulation of beta 2 receptors. It's going really deep into anatomical pathways.
It is,
and we don't typically remember kind of focus on those. But I will say I'm not 100% sure on this. Are you?
I'm going with number 4. And the only reason I'm doing that is the relaxation of the bronchial smooth muscle, which would go along with the idea of dilating versus constricting.
Mm-hmm.
So the only thing that throws me is I don't know the actual physical answer with the beta 2 receptors. It's just not something that's clicking in my head as remembering that from
Me neither.
the course. But that relaxation of the bronchial smooth muscle to me says it's not constricting it, it's dilating it.
Yeah, and reduction of airway inflammation doesn't seem to me like airway may not mean like the areas of the lungs that have to do with bronchodilation. So that's one that's thrown off that first one for me. And also I don't think that, I know for sure that albuterol is a steroid. It is not an antihistamine.
Right.
So that's what I'm kind of basing this off of and saying, okay, I'm thinking the beta 2 receptors are part of that, the inflammation cascade. So I would say, I'm locking in on number 4, stimulation of beta 2 receptors causing relaxation of bronchial smooth muscle.
That is correct.
Yay. There's a long walk around the block, but we got there.
So the key in this is that it's an agonist for beta 2 receptors. And that is what we're trying to do. We're trying to dilate the bronchioles, right? So, albuterol doesn't do anything with histamine. That would be one of our antihistamines like Benadryl.
Right. Diphenhydramine.
So the big thing again is that beta 2 receptor. So that's exactly what albuterol works on.
Yep.
And this is a tricky question because you get all that information at the top of the question, and then the actual
doesn't matter.
You get the actual question. It doesn't matter because the actual question is, what does albuterol do?
Yeah.
Right.
And sometimes what they want you to know is not necessarily just the basic level of, it's a bronchodilator. But what is a bronchodilator? Then you should have some idea of anatomy wise what that's doing.
Yep.
Like it's opening up the alveoli. It's not just opening up the airway, because the airway can be your, the trachea and the mouth and the upper, there's a lot to that other than just dilating the bronchioles, right?
Yep.
This is where your pharmacology flashcards with your mechanisms of action are a good study resource for you.
Yes.
So,
well, thank you, Jonathan, for testing us for one more week, and we're doing pretty good.
Yeah, we're doing really good.
3 for 3, like 5 weeks in a row, 6 weeks. I haven't been keeping track, but we should.
We're just gonna say for all the weeks. Just go with that.
No, those first weeks are a little rough. But I remember looking back and being like, oh, these were hard. And now I'm like, well, they're hard, but I know them.
Yeah.
And it's fun. It's fun to kind of recognize that you've made progress. So, all right. Well, with that, I think we've certainly talked enough in this episode. It's probably one of our longer ones. But let us know how you're doing. Please share with us your journey. And thanks for taking the journey with us. And we'll see you next time on the ride along. This podcast is for educational and storytelling purposes only. It is not medical advice or official EMT training. Always follow your accredited instructors and local protocols.
Heartbeats racing in